introducing Dr. Bide sir, and then I will then after welcome address I'll introduce you. Then probably you can introduce me, and then we can start or something like that. Chala. Great.
Looking forward to a great webinar.
Yeah. Yes, Dr. Anaga. Yes, you are back from Jaipur. Good.
We are live. We are live.
Yeah. Good evening, friends. All our colleagues from Maharashtra Ophthalmological Society, as well as from All India Ophthalmological Society. We welcome you all from the Maharashtra Ophthalmological Society. Friends, we all know that glaucoma is a leading cause of irreversible blindness, and more than 78 million people suffer from it around the globe. And that's why every year, the World Glaucoma Association celebrates a Glaucoma Awareness Week. And this time we have recently celebrated it, and that ended just 2 days back. This year's theme was "The World is Bright and Save Your Sight." And actually every attempt which is done to create awareness about glaucoma, not only amongst patients, but also amongst our ophthalmology colleagues, about right practice patterns and to improve the general standard of glaucoma care around the world, I think it should be more and more emphasized, and every effort should be taken about the same. So we are happy from MOS. This month has been dedicated to glaucoma. We have tried to create 5-minute master classes, the series of it, and also this is a very unique webinar which has culminated by efforts of our expert panelists and expert speakers who have joined us from all over India. All of them are some of the biggest names and opinion makers that we know in glaucoma management. And today we are going to actually deal with something unique, which is the top mistakes that we all do when we do glaucoma diagnostics as well as glaucoma management. This webinar is going to be directed mainly towards comprehensive ophthalmologists, which are the backbone of the care in every part of India, but of course, mainly in the Tier 2 and Tier 3 cities. And we are very glad and thankful to all the faculty to have found time and for all their efforts. So first, I would like to welcome our chairman of this webinar, the president of Maharashtra Ophthalmological Society, Dr. Santosh Bide sir. Dr. Santosh Bide sir is a leading ophthalmologist and a senior anterior segment surgeon from Pune. He has spearheaded MOS in a very dynamic association. He's a very dynamic and supportive leader who has taken a lot of unique initiatives during his presidency. And I would like to request him for welcome address. Over to you, Dr. Bide sir.
Yeah, thank you, Dr. Vardhaman. I'm sorry my video is not going to start. I'll be from the background observing everything. We at Maharashtra Ophthalmological Society have one vision, and that vision is to update knowledge of all the members, not only from Maharashtra, but from all over India. And in those efforts, we have taken a lot of webinars like Safety First webinars, then webinar for the OT management. And since the month of March is devoted to disease glaucoma, we have come up with this unique webinar. Usually in a webinar, we talk about how to manage, but here we are going to talk and focus more on what are the common mistakes which we do in diagnosis as well as management, and how to avoid them, and how to give a better treatment to all our patients. We are really happy to have esteemed faculty from all over India. And without wasting time, I request you, Dr. Vardhaman, to introduce the faculty, and let's begin the scientific treat to everybody. Over to you, Vardhaman.
Thank you so much, sir. So I think the first, I would like to invite and introduce our co-moderator, Dr. Preeti Kamdar ma'am. Dr. Preeti Kamdar madam is a glaucoma surgeon practicing in Mumbai in Dr. Kamdar's eye clinic in Matunga, which has a legacy of 100 years of eye care and is a center of excellence for both glaucoma and retinal diseases. She has been invited faculty in many national and international forums, and she is involved in teaching postgraduate ophthalmology students. She has also served as the member of managing committee in BOA and she has currently the zonal member of MOS Managing Committee. Dr. Preeti Kamdar has been honored as a Woman Achiever in 2021 by the Government of India under the Beti Padhao, Beti Bachao initiative. And she's a very prolific glaucoma specialist, and we are lucky to have you as co-moderator today.
Thank you, Vardhaman, for the very kind introduction. But now it's time to introduce you, a very young, dynamic person. Dr. Vardhaman is the chairman, scientific committee of Maharashtra Ophthalmic Society. And though young, he has over 60 international publications and is on the editorial board of 4 international journals. That's really amazing, Vardhaman. He's the founder director of Asian Eye Hospital, Pune, and is the recipient of AIOS Refractive Award, Asia Pacific Refractive Award, AIOS Cornea Award. Wow, I mean, there's so much. IIR SI Gold Medal, and our own MOS highest scientific award, that is the Dr. B.K. Chitnis Oration Award. So Vardhaman, kudos to you for bringing this amazing program together. And I think we can now start. You can just introduce the rest of the faculty.
Thank you, ma'am. Thank you for your kind words, madam. And I think now we have our expert panel, which comprises of some of the best experts that we have nationally. To begin with, we have Dr. Siddharth Dikshit. He is from LV Prasad Eye Institute. He did his DO from Christian Medical College and followed by his DNB and fellowship at the LV Prasad Eye Institute in Glaucoma. He has many national and international publications to his credit and is a lot involved with newer innovations. We, of course, have Dr. Rita Dhamankar, ma'am. She is a pioneer of glaucoma specialty in Maharashtra. Ma'am is a deputy medical director at Lakshmi Institute in Panvel and also head of the optometry department of the Lakshmi Institute of Optometry. She has been a very prolific speaker at both national and international forums. We have Dr. Pradeep Vyas sir. Pradeep Vyas sir it is almost a homecoming because sir has spent a considerable amount of time also in Maharashtra as the chief of Ganpati Netralaya. Sir has done his glaucoma and VR fellowship from LV Prasad Eye Institute. And after his stint at Ganpati Netralaya, he is currently the medical director of the Center for Sight in Indore and is one of the most prolific names that we have both in glaucoma nationally and recognized also internationally. Sir has been awarded with many awards, but one of the chief awards is the Marathwada Ratna Award from the Marathwada region given to him for his honor. Then we have Dr. Professor Ramajit Sihota, madam. She is the chief at the Shroff Eye Center. Dr. Ramajit ma'am has been the previous chief of the glaucoma services at the prestigious RP Center at AIMS in New Delhi. And she has been one of the pioneers of glaucoma care in India. We have Dr. Shefali Parikh ma'am from Mumbai. Dr. Shefali Parikh madam has been a flag bearer and has worked a lot in the Glaucoma Society of India. She has been the West Zone representative of GSI between 2020 and 2022. She has also been one of the co-chairs of one of the first preferred practice pattern bulletins which were created by the GSI for the benefit of our glaucoma specialists and comprehensive specialists as well. And all of them are going to give us their words of wisdom along with all those excellent speakers that we have in all the sessions. So as we know, Dr. Preeti ma'am, we have 4 sessions to begin with. And as we discussed, we are going to have one session. So all the 3 speakers are going to give their talks. And at the end of the 3 talks, we are going to have a good discussion for about 10 to 15 minutes after each session. Such we have 4 different sessions with us. So the first session is going to be, of course, the mistakes that we all do during the clinical examination. And the first speaker that we have is Dr. Sachin Dharwadkar. Dr. Sachin Dharwadkar is a very prolific glaucoma specialist working for many years in Mumbai. He is also consultant at PD Hinduja Eye Hospital. He's going to speak to us about the mistakes in recording intraocular pressure. Over to you, Dr. Sachin.
Yeah, thank you, Vardhaman. Am I audible?
Yes.
Yeah, I'm trying to share my screen. Just tell me if it is seen. Is it seen?
Yes. Yeah.
Okay. So I would be just mentioning around 4 to 5 important points in the the mistakes that we can commit during IOP measurement. And these will be only the salient points, so that each will be a take-home message, so that we don't repeat this in the clinic. We know that tonometers are multiple, but in common use, we have around 4 types of tonometers. That is the Goldman and the Perkins. Those are the application tonometers. And then you have a non-contact tonometer and the rebound tonometer. Now, these are very, very commonly in use. That's why we will discuss only. I'm only mentioning these, and we'll discuss only mainly about the Goldman and the Perkins, because they are the gold standard for management in glaucoma. Important thing that we should know is that the Goldman and the Perkins have a subjective element to their measurement, whereas the non-contact tonometer, that is the NCT, and the rebound tonometers basically have more objectivity to it, which can be collated in case we have doubt with the previous 2 measurements. So the first important point, really funny, but in routine practice, not measuring IOP is the biggest problem or the top mistake is not measuring the IOP at all. Sometimes we find in many people, many patients, that the IOP is not measured, and we do not have really an excuse in today's world. And secondly, not measuring the IOP yourself. What happens is, in the setting of a glaucoma management, if you do not measure intraocular pressure yourself, then it is a very big problem, because then the due diligence that is required for a proper IOP measurement is huge nowadays, especially in the setting of periorbitopathy and deep-seated eyes. You cannot depend on somebody else's measurement and take clinical decisions in glaucoma. Second important fallacy is that not using the right device. Now, multiple devices are available in the gamut, and people, there are many people using different devices. But you have to remember that when you are treating glaucoma, there has to be a uniformity and a gold standard that has to be used, because the other devices have their own errors and different measurement ranges. So you should know whether you are screening patients in a normal OPD population, or you are in serious glaucoma diagnosis and management. In case you are doing glaucoma diagnosis and management, you do not have a choice but to use applanation tonometry, that is either a Goldman's or a Perkins. So this is a mistake that you should avoid. If you are managing glaucoma, please do not use any other tonometers, because they have their own limitations beyond the routine measurement ranges in high or in the low. Third thing is, it is very important for us to make sure that the devices that we use have been calibrated well. If you do not calibrate the devices properly, then the measurements will definitely be erroneous. The calibration should be ideally advisable monthly. In case the instrument is found to be off calibration, it has to be sent to the manufacturer for recalibration. I have these small videos, but I wouldn't play them for the sake of time, because we have very short time interval here. So we can show them in case they are asked in the question answer session. The fourth most important thing is that these measurements are often influenced by inappropriate patient positioning and pre-measurement checks and lack of proper instructions. Now, this is very important, because if you do not instruct the patient or position the patient properly, it is especially sensitive. The Goldman's application tonometry is especially sensitive to these measurement errors. So you have to give proper instructions to the patient, spend proper chair time. This will prevent the Valsalva related intraocular pressure changes that can occur because of patient stretching his neck. Alignment of the canthal mark is very important. You have to address tight clothing. Neckties are not very common in our scenario, but definitely if the buttons are tied right up to the neck, definitely they can cause a inadvertent Valsalva maneuver. Also, the forehead has to be flush to the headrest comfortably, and the patient should, what we can say, fall over onto the headrest. If there is a gap as shown in this picture, then definitely this causes an increase or overestimation of intraocular pressure. So these are the small things that we should always know. Staining and illumination of the precorneal tear film is very important. Nowadays, in the setting of multiple glaucoma medications, you have a lot of dry eyes and very poor tear film. In these cases, it is very important to stain whatever the tear film is available adequately. And the complicated staining pattern of the ocular surface also complicates the measurements. More wetting time should be given for the fluorescein strips in such cases, and more cul-de-sac residence time for the fluorescein is required. Otherwise, the poor staining of the tear film will lead to an artifactually low intraocular pressure. Waning batteries, spoiled filters of Perkins tonometers were a very common problem in the MK1 type of tonometer. That led to the understaining or under visualization of the Myers, and that leading to the underestimation of IOP. With the new MK2 tonometer with the magnifying graticule as well as the LED lights to illuminate the tear film or the Myers, these problems have by far been solved. So longer wetting times should be used with MK2 type of Perkins tonometer, and this can give you very accurate intraocular pressure readings. Excess stain and understain, as I have told you already, are major problems. Thinner the Myers, you get underestimation of intraocular pressure. Meyer width should be ideally less than approximately 1/10 of the diameter of the applanating surface. In case the Myers are thin, you have to repeat the staining and repeat the readings. In case there are thicker Myers, they tend to overestimate the intraocular pressure. So you have to blot the excess stain and repeat the readings. These are very, very important facts because even a few millimeters make a difference, especially in advanced glaucomas. You can also have cleaning issues when you are in intersession, when you are changing from one patient to another, non-drying of the tonometer tip after cleaning with
6 minutes
isopropyl
are
alcohol.
up.
Sorry?
Sachin, 6 minutes are up.
Okay, I'll just finish with a couple of slides. So you clean immediately after seeing the patient so that it can allow the drying of the prism head sufficiently and prevent this. Intraocular pressure in the era of periorbitopathy is a very big problem. Palpebral fissures are narrow. Even retracting a bit of fissure can increase the intraocular pressure by a lot. So the ideal technique is to pull the eyelid away and not pull the eyelid up. You have to pull it away from the eyeball as shown in the figure, or sometimes you may have to resort to reclining the patient and using a Perkins applanation tonometer instead of a Goldman's to prevent the inadvertent pressure on the globe. You have to ignore astigmatism at your own peril. You have to understand to keep the assumption of the Imbert-Stick principle intact. You have to have the applanated area of around 7.3. In case of astigmatism more than 3, this can be achieved by aligning the flat meridian with the red mark, which is shown on the stand of the prism mount. And this is the example. I'll not read it for the shortage of time. Always remember that bias and trusting a single IOP reading are always problems, especially in Goldman's and Perkins, because they are, as I said, subjective techniques. So procedural mistakes are common in lieu of time and surgeon fatigue, and bias is a second human nature. So we have to remember that in case we find an abnormal intraocular pressure, rather than jumping the gun, it's important to repeat the intraocular pressure in the same or different session and in a relaxed manner. And always keep an objective device ready just in case you want to double check, especially in the normal intraocular pressure ranges. The last point I would like to stress is missing the details in clinical examination and history can also be a dangerous thing, because just like in this case, if you miss interface fluid or if you miss interface of refractive surgery, then underestimation of IOP can grossly land you in problems. So detailed clinical examination is always important, and you can again go back to the intraocular pressure and put it into perspective. So it's very important for us to understand all these points and not miss a single one in case, so that we can manage our glaucoma patients better. Thank you for your patient hearing.
Wonderful. Thank you so much, Dr. Sachin. I think it was a very concise yet very comprehensive, let's say, a bird eye view about what are the common mistakes that we all make during taking applanation tonometry. And at the end of these 3 talks, we will have more discussion about the same. So Dr. Preeti ma'am will go to the next talk. Yeah. So the next is Dr. Kunal Nikale. Dr. Kunal is from Nasik. He's a glaucoma specialist who has done his glaucoma fellowship from the prestigious Arvind Eye Hospital. And he's going to speak to us about the mistakes in gonioscopy. Over to you, Dr. Kunal. Thank you.
Thank you, Dr. Vardhaman. At the outset, I would like to thanks Maharashtra Ophthalmic Society for the opportunity. I hope my slide is visible.
Yes.
Is it?
Yes.
Yeah. I'll start with my topics, mistakes in gonioscopy. Gonioscopy, by introduction, it's a fundamental part of comprehensive eye examination, which determines the topography of the anterior chamber angle. it is normally the rays from the antechamber are not visible due to total internal reflection, and with the help of gonio lens, we can replace the cornea interface by new interface of gonio lens. Two types of gonio lens as can be there. We have direct gonioscopy, which uses convex lens on the cornea. It is done in supine position with the help of binocular microscope. You can see Barkhan's illumination is used for illumination. Different types of gonio lens are Capet, Leiden, Barkhan, Swan Jacobs used for gonio lenses.
Can we
As I
ask
said,
him?
I'm saying the only first slide is not going forward.
Sorry.
I'm saying only the first slide. Is it for all or for me only?
No, it is only the first slide, and he is not in full screen
Yeah,
mode.
slideshow.
You'll have to
Please
go to
go
the
to full
slideshow.
screen mode.
So you need to put it as slideshow bottom.
Slideshow, yes.
Okay, is it now?
Yes.
Yes, sir.
No, not yet, not yet.
No, not yet.
Click on it, please. No, not yet. Or you can go to the slideshow on the upper bar.
Upper.
कुणाल वरती slideshow आहे.
Sir, can you stop and reshare? Dr.
I'll-
Kunal?
Yes.
Yeah,
Sir.
yeah, you can
Stop
stop
share.
the share and then, yeah. And type
Then reshare.
reshare.
Yes. Yeah, we can see now. Kunal वरती slideshow आहे. नाही, we can see now slides.
But my slide is not going up and down now.
Right click केलं तर जाईल ना.
Probably you can escape and then you can start again. I mean, go to the slideshow again.
So just click on the screen. So just click on the screen. You should be able to do it. Just click on the screen. Yes.
Yes.
Perfect.
good.
It's visible now?
Yes, yes, yes.
Yeah. So
Please
in
go
the gonioscopy, it uses a mirror to overcome the total internal reflection, and the mirror redirects light so that light exits the eye perpendicularly, and we can see it through the slit lamp. Different gonio prisms are Goldman 1 mirror, which has 12 mm central well, Goldman's 3 mirror, Zeiss 4 mirror, Posner, Thorpe, Sussman, and many more lenses. Now, the indications of gonioscopy can be to study the topography of the antechamber angles, to see the neovascularization, pigmentation, angle recession, foreign bodies, neoplasia, study the patency. Indentation gonioscopy can be a therapeutic gonioscopy to break the acute angle attack, and different gonio procedures can be done with the help of gonio lenses. Contraindication being any suspicion of open globe injury or infection, corneal infection, or any ulcers, hyphema, early post-operative cases. Now, the common mistakes what we do in gonioscopy is not doing gonioscopy routinely. So the survey done by Fremont et al., he studied that gonioscopy done in initial visits for glaucoma in US was only 46% and 23% in UK. Not doing gonioscopy routinely is a big mistake. Inability to identify angle structures correctly, improper gonioscopy technique, mirror imaging can be confusing and can lead to mistakes. And the opening of the angles artificially with pressure is another mistake. These are the different landmarks which we can see on gonioscopy. The important being corneal wedge. The two beams of light from the anterior and posterior surface of the cornea, they along with the corneoscleral junction, they converge at the apex, and this is the site of Schwalbe's line, which is the first structure seen from the anterior side. This identifies the trabecular meshwork, and which can be helpful in difficult angles like angles which are heavily pigmented, which have extensive iris process, cohesive cornea, and have pigmentation of the Schwalbe's line. Schwalbe's line can be it's a thin translucent line which is a collagen condensation of Descemet's membrane between trabecular meshwork and corneal endothelium. So pigmented Schwalbe's line can be mistaken with a trabecular meshwork, and the corneal wedge what we just discussed, it helps to rectify that mistake. Trabecular meshwork, by gonioscopic appearance, it appears ground glass. Anterior part is non-function, which is white, and posterior part is functional, which it is pigmented and seen as a grayish blue in gonioscopy. Schlemm's canal normally not visible, but blood in the Schlemm's canal makes it visible. Blood in the Schlemm's canal can appear with pressure on the gonio lenses in CCF, Sturge-Weber syndrome, hypotonia, and other conditions. Scleral spurs, it is an important landmark which is related to consistency in appearance, and it is a site of attachment of longitudinal muscles of ciliary body. Ciliary body, it appears as a slate gray band on gonioscopy, and the width depends on the position of iris insertion. The narrow in hyperopes and it is wider in myope. Angle recession is the tearing of the longitudinal and circular muscles of the ciliary body. Mistakes can be to identify between iris process and pars. Iris processes are fine and extend into scleral spur and follow the concavity of the recess, whereas pars, they are broad and they extend beyond the scleral spurs, and they bridge the concavity or the recess. The iris process can be broken with angle recession, whereas pars, they remain intact. Sampousi line, it's a irregular pigmentation of Schwalbe's line. The Sampousi line can be mistaken for pigmentation of trabecular meshwork. Now, coming to the procedure, which lots of mistakes happen. The Southeast Asian Glaucoma Interest Group, they define some protocol for the procedure. Always explain the procedure to the patient. Tell the patient that something will come near to the eye, and we won't put any lens on the cornea. So counseling is important. Dim light has to be there. Slit lamp beam of narrow beam. 10x to 25x zoom can be there. Application of anesthetic is important. Proper positioning of the patient. Lateral canthus of the patient has to be near the lateral canthal margin, so that vertical excursion is possible to see the upper and lower images. Slit beam should not cross the pupil, as constriction of the pupil can open up the angles. Avoid excessive pressure on the eye, so that angles don't open up. And the view, it is 180-degree image, so it's a mirror image and not an inverted image. So by technique, ask the patient to look up, and the gonioscope should touch the inferior part of the eye and apply over the cornea, and ask the patient to look straight. So with Goldman's lens, we have to avoid indentation on the peripheral cornea, so that we don't artificially narrow the angle. And in case of Zeiss lens, we have to avoid pressure on the central cornea, so that artificial widening of the angle doesn't happen. So with 4 mirror
lens, 6
yes,
minutes are over. So if you
yes,
could just sum up, yeah.
Just a last minute, ma'am. Yeah. Sure. The dynamic indentation gonioscopy, it is possible with 4 mirror lens. It can differentiate between appositional closure and synechial closure. With indentation of central part of the cornea, the aqueous this spreads to the posterior part and opens the appositional angles, whereas the synechial angle closure don't open up. Indentation gonioscopic is also helpful in plateau iris configuration. On indentation, the peripheral roll of iris does not flatten up with indentation in case of plateau iris, and we get a sine wave of double hump pattern. In case of steep iris configuration and narrow angles, we can define, or we can be mistaken for closed angles or angle closure. With manipulative gonioscopy, looking over the heel with the help of Goldman's lens, ask the patient to look in the direction of the mirror and move the lens towards the angle being viewed, so that the angle structures are visible. So the gonioscopic classification, it's dependent on the different angle structure. So defining and decoding the angle structures is important.
Dr. Kunal, if you could
last slide, with gonioscopy, again, it's a poor documentation of findings is there. It has got a steep learning curve. It's a contact procedure, and a partial agreement between the two examiners, it is possible. And impractical photography of the observed findings, and it has got limited gradings or measurements. Thank you. Thank you for the patient hearing.
Thank you, Dr. Kunal. It was a very nice comprehensive presentation with a lot of pictorial photographs also for our comprehensive ophthalmologist colleagues to learn in terms of having a good, because gonioscopy is a very pictorial thing, as you know, it's a visual thing. And thank you so much for doing your efforts to compile all these things together. Thank you again. So I think the next we are going to have Dr. Rajul Parekh sir is going to, Dr. Rajul sir is the director of the Sriji Eye Institute and Palak Glaucoma Center in Mumbai. Sir is a very prolific glaucoma specialist on the editorial board and also the International Glaucoma Review since 2018. He is the member of the Educational Committee of the World Glaucoma Association from 2018. He is the Associate Advisory Board member of WGA and a section editor of Glaucoma Session for Indian Journal of Ophthalmology. Dr. Rajul sir has 65 publications in peer-reviewed journals and has written 17 chapters and has also contributed to the World Glaucoma Association's consensus book. He is currently the chief editor of Glaucoma Society of India's the guidelines, the first edition of it. And we are very lucky to have sir as a speaker in this session. And in this part of the clinical evaluation mistakes, sir is going to speak to us about mistakes in disc evaluation. Over to you, sir.
Thanks, Vardhaman, for a kind introduction. My voice is clear?
Yes, sir.
Okay. So I'll be talking about the mistake we commonly make during optic disc examination. Since we have only 6 minutes, I will try to cover most important point. Now we know optic disc examination is very important for the diagnosis as well as, of course, progression. But if you look up some of the studies, the optic nerve can pick up the damage much before the white on white perimetry. So the careful optic disc examination is very important part of the not only glaucoma, the comprehensive eye examination. Now I'll just try to cover 5-6. The most first and the most important, how do we examine the optic disc? It cannot be the direct ophthalmoscope, definitely not indirect ophthalmoscope, because indirect, of course, is stereoscopic, but it will be a very minified view. Direct is monoscopic, so you cannot get depth perception. So it has to be slit lamp, preferably with 60 diopter or 78 diopter. 90 diopter I will leave for the expert because again it minifies. So 60 diopter and 78 diopter is good on slit lamp. The second, we rely heavily, or the lots of people rely only on cup disc ratio for the diagnosis of glaucoma, and that's one of the biggest mistake. We know that the cup disc ratio basically is the leftover space. Now, if you look the SCAM scanner, the size varies. The number of fibers is more or less same, around approximately 1.2 million axons pass through the disc. Now, disc size it varies. It can be a small disc SCAM canal, large canal, and the leftover space. The leftover, this is the axons, and the leftover space is the cup and cup disc ratio. So if you have a small disc, the leftover space is very small and the cup disc ratio is very small. If you have medium size, the leftover space is medium and you have medium cup disc ratio. And if you have large disc, the leftover space is huge and the cup disc ratio would be big. So only alone cup disc ratio is not important for the diagnosis of glaucoma because it varies depending upon the disc size. So this is very important message that only cup disc ratio is not important. If you want to look, that has to be in isolation with the disc size. Now, of course, I'm not saying cup disc ratio is not important. More than 0.7, the chances of being in normal population is 5% or less. So high cup disc ratio is suspicious. If you document the increase in cup disc ratio, now if you have seen 5 years back, and now this is definite glaucoma. The progressive increase in the cup disc ratio is suggestive of glaucoma. If you have 2 eye, you see this cup disc ratio is small, this cup disc ratio is large. So the asymmetry of more than 0.2 is also very suggestive of glaucoma. But alone, cup disc ratio is not important. So please do not rely only on cup disc ratio. Third, we rely heavily on ISNT rule. Now, what is ISNT rule? ISNT rule says that inferior rim is thicker than superior rim, is thicker than nasal rim, which is thicker than temporal rim. Yeah. So this is inferior, which is thicker than superior, which is thicker than nasal, and temporal is thinner. Now this is in normal population, this rule most of the eyes will follow, but if you look the data, the Caucasian eye, the specificity, that means the chances of the normal having the eye center rule is approximately 85%. But Indian eyes, the optic diseases are different, and most of the data suggests that the specificity is 65 to 70%. So some of the normal eye also may not follow the eye center rule, and that the reason is because the disc size varies, the axonal, the nerve fiber, the way it distributes around the optic disc margin varies. So if it's a large disc, the distribution would be equal, and you may have an inferior rim which is equal to the superior rim. So that's why the ISNT rule also alone again is not important. So you have to look other parameter also. The 4, we miss out in the early changes by not looking the contour of the rim. Now contour of the rim, the stereoscopic examination is very important. This is normal contour. In early changes, you have a inferior rim thinning and just the saucerization. So this saucerization is a very important sign of early glaucoma. And if you don't do a proper stereoscopic examination, you will miss out the early saucerization, you will miss the early changes. 5, looking the red-free filter is very important. This is the normal red photograph. Yes, I can make out the RNFL because I'm doing this for 25 years, and most of these glaucoma people would make out. But this would be more visible when you look on a straight line with the green light, red-free filter. You can also pick out the superior wedge-shaped defect, which here, now, yes, you can make out, but in just a cursory examination, you may miss this wedge-shaped defect. So red-free is very important. 6, differentiating with myopic disc. The myopic disc, we have to be very high index of suspicion. If you look, in fact, ask George Jonas, he will say that all myopes are glaucoma unless put otherwise. That means you have to be very high index of suspicion because the thinning, the notching is all masked because of the very high peripapillary atrophy. So you have to be very careful in clinical examination. If you have a 2 mirror, if you put the 2 mirror with a coupling fluid and use the central lens, you will be able to differentiate the notch much better than just the 60 or 78 diopter lens. And the last differentiation with the neurological disc. Now here you have to make sure that know the basic principle that pellar out of proportion of cupping is neurological. Whenever you doubt, anyway we require perimetry for the glaucoma workup, do a perimetry. The field respecting the vertical meridian is neurological. So disc size, cup disc ratio, neuroretinal rim, NFL defect, disc hemorrhage, peripapillary atrophy, all are the signs we should look, and there are some more. I'm not going to go in detail. And the last slide, this is a Professor George Jonas rules. All disc glaucometer changes. That means you have to be very careful when you examine even a normal patient, normal person, whoever has come to your clinic, you have to be very thorough in your examination. Second, all glaucoma have RNFL defect. That means you look carefully, use the red filter. Third, all glaucoma have disc hemorrhage. The same principle. Examine every disc thoroughly, and you make sure that you don't miss any finding.
Raju,
And
6
all
minutes
myopes have
are
glaucoma.
over.
So these are the 4 points. Thank you.
Thank you, sir. It was such a precise presentation. I think we have really learned a lot in a very short 6-minute time. And thank you so much for putting things together. Over to you, Dr. Preeti ma'am, for the panel discussion.
Okay, so right now we have our esteemed panelists. So my first question is to Dr. Siddharth Dikshit, that we find many ophthalmologists, they use NCT as the screening device. So all patients are put through screening. And in some centers, even glaucoma is treated on screening. That we all disagree. But what would you say? Do you validate the use of NCT as a screening tool? What would be your take on it? Dr. Siddharth. He's there.
Dr. Siddharth, you're mute, I think.
Yeah.
You'll have to unmute yourself. Yeah.
Sorry for that. I thought I was a Zoom webinar specialist, only to realize it now. Thank you so much for having me here. Thank you, Dr. Rajul, for a wonderful talk. I didn't know that disc examination could be compressed in 5 minutes. Coming back to NCT, let's be practical. Let's be practical. And let's realize that more than 70-80% of private practitioners are going to use NCT for most of their patients. What we need to realize is that the moment the intraocular pressure reading goes above 17, 18 millimeters of mercury, you need something better, because the NCT is known to have variations even within normal range of intraocular pressures. And as you said, a screening tool, yes, to treat glaucoma and to treat that intraocular pressure measurement as an accurate measurement, no. So the moment a patient becomes diagnosed as glaucoma, or even a glaucoma suspect, primary angle closure suspect, or primary angle closure, you need to move to Goldman applanation tonometry, and that's where the crux lies. So while realizing that there needs to be a practical application, but for the patient, we need to do it. And if you want to have an ideal setup, you want to give the patient the best every time they come to you, there's no alternative to Goldman applanation tonometer.
That's a message well received. So for the comprehensive ophthalmologist, one, yes, you may use NCT as a screening tool, but remember, it's just a screening tool. All of us come across patients where they've been treated on for glaucoma on NCT, and that's completely, there is no justification, no excuse for not using applanation tonometers in glaucoma suspects or pressures who have elevated IOP. And busy practice is no reason. So that is one thing, NCT as a screening tool, and whenever in doubt, always applanation. So Dr. Dikshit, that's what we would summarize. Is that right?
Yes, yes, absolutely.
Oh. So my next question is, like, the most common mistake in gonioscopy is not doing it. So Dr. Rita, we have Dr. Rita with us. So can you tell us how can we encourage a comprehensive ophthalmologist to do gonioscopy?
So, in my opinion, yes, that is the number one mistake. But the easiest thing I think to do is to, let them know that they see so many patients on a daily basis on the slit lamp. So it's just another additional 2 minutes if they learn to do gonioscopy correctly, and it will help them in so many ways. And I think if they feel that it is dangerous, or it is difficult, or it is very time consuming, that it is very messy because you use fluid in between, and then the whole eye needs to be wiped off and all, I would suggest two things. One is, when you are learning your gonioscopy, please do it on every patient who comes to you with a one mirror gonio, because that is easy to see. If any one of you has used a one mirror, you will realize that you can see all the structures very well, and all that you have to do is keep rotating the lens, so you see all the 360 degrees. Once you have learned how to identify all the structures on the one mirror gonioscope, then I think the next shift should be to a 4 mirror. It should not be to a 3 mirror or a 2 mirror at all, so you don't mess up the eye with fluid or anything. You have a small lens, you learn to handle it carefully, and you can see the entire angle very nicely, and indent the you can indent the eye, and you can get you can diagnose angles which can be opened, which may look closed to you, but on indentation they open up, and so you can make a very easy diagnosis. I think it's just that you have to learn to realize the importance of doing a gonioscopy. You're looking at every patient on the slit lamp, spend 1 extra minute, just spend a few more 1,000 rupees to get yourself a good gonioscope. I would certainly suggest a 1 mirror to start with, and then to the 4 mirror, because it will save you a lot of problems in the future. All the pigment, the foreign bodies, the silicone gas bubbles, there are so many things that you see. The neovascularization, you've done a trab, you can see the trab opening. There are so many things that you see on that gonioscopy, and it will save you a lot of trouble in future. You don't put yourself into trouble because you've already done the gonioscopy and you know what to look for.
So thank you, Dr. Rita. So first is Dr. Siddharth also has raised his hand. So Dr. Siddharth, what do you want to say on it?
I hate to indulge myself, but I'm sure Dr. Rajul will support me because we are brought up on the same genes that Dr. Ravi Thomas transmitted. And I'll tell you, as a postgraduate resident, even if I was a candidate for diploma in ophthalmology, I was made to do gonioscopy and perform indirect ophthalmoscopy for every patient that I saw. Now, I thought it was a wasteful exercise. And only with time, over probably 2.5 years, I realized what it made me capable of. For the entire first year, I didn't understand a thing what I was seeing on gonioscopy. But the moment I incorporated my experience of what I was seeing with gonioscopy.org videos, I started realizing what I was seeing. And what Madam said, that the 1 mirror or 2 mirror gonioscope gives you the best possible view that you can get and helps you overcome the initial challenges of the patient not being cooperative, you not being able to have a stable view. That can really be overcome with a coupling fluid. But ultimately, when you do it on a regular basis, it becomes a 30-second examination. And that, I believe, we owe it to all our patients, as Madam said, and that's just 30 more seconds of your life. Even if you see 40 patients, it means only 20 more minutes. It only means 2 more YouTube short videos. It only means half of a webinar or a web series episode. We owe it to everyone on a daily basis. And one more thing, when Dr. Rajul said about examining the disc, that completely reminded me of the fact that we need to examine a disc stereoscopically. And the Hack Street slit lamp, if you move it from side to side, it has 3 clicks. 1 click is right at the center, and the 2 others are at 10 degrees. And if you go to the 10 degrees position and use your 90D with high magnification or 70D, 78D with the normal magnification, that's the best stereoscopic view that you can get. And we should use those clicks. Those clicks are for our benefit, and we should utilize them.
Dr.
Sorry for
Siddharth?
taking the time.
No, that's okay. Dr. Siddharth and Dr. Rita, wonderful tips. So first is buy a gonioscope. First, buy a 1 mirror small gonioscope, which is easy to use. Do it in every patient. So one last, we have about 3 minutes. We had kept about 12 minutes for discussion. So we
Can I
also
add something? Can I add something?
Yeah, I'll just go to the next. Okay, sure, Shafali, please.
Yes. So basically, all the speakers have definitely done justified their talks, but there are a few things which I would like to add. One, in IOP, what I would like to say is never base your diagnosis only on the basis of intraocular pressure reading. You have to take full clinical picture into account. Never rely or never manage your patient based only on the one IOP reading. You have to take multiple intraocular pressure readings. Third thing is not to use the nomograms, that is the CCT. There are a lot of formulas and nomograms, but don't use those nomograms for your managing the glaucoma patient or correcting your intraocular pressure while managing the patient. And regarding gonioscopy, what Dr. Siddharth has said correctly, only thing is indentation I would like to add, because ultimately we have to shift to indentation, because indentation gonioscopy also helps to identify the number of synechia and not only number, but the extent of synechia. So whenever there is any change in the clinical picture, gonioscopy must be done. Of course, it is 6 monthly to 1 yearly, whatever the guidelines. But whenever you see any change in the clinical picture, that is the high time to do the gonioscopy again. And I think disc, again, the same thing. Always that you don't have to do your diagnosis or management based only on IOP or disc. It has to be the full clinical picture that has to be taken into account. Thank you.
Points well taken, Shefali. We also have Dr. Pradeep Vyas with us. Can you unmute yourself, Dr. Pradeep Vyas?
Yeah, hi, good evening.
Hi, good evening. So Rajul has given a very good overview of mistakes in disc evaluation. What are your 2 points, which if you want to add anything to it? What would be your message to a comprehensive ophthalmologist while examining a disc?
Okay, so Rajul has beautifully covered the disc examination in a very short time. I would just like to emphasize, whenever you are examining a disc, you must differentiate the normal disc from the abnormal disc. Now, the abnormal disc could be glaucomatous, could be a congenital anomaly, or could be some other pathological disc, like neurological or a traumatic. So all these things, you must know that how to differentiate this disc from a normal disc. And every individual has a different disc. Even the normal discs are different in different individual. Even in the two eyes of a same patient, it differs. Okay, so that all things you have to keep in your mind, and you must do a good stereoscopic examination. Keep all the points in your mind and remember that most of the patients are geriatric patients. So never ever miss the senile sclerotic disc as well. So you must identify, otherwise you will keep on getting confused. Senile sclerotic disc with a glaucomatous disc, and unnecessary that patient will be treated. This point should be kept in your mind.
Points well taken, and thank you for those tips. So, Vardhaman, we can go over to the next session.
Yeah, thank you, ma'am, for wonderful panel discussion. Before we go to the second session, I would like to introduce two of our very important MOS panel. Dr. Anaga Herur, who is a very dynamic secretary of Maharashtra Ophthalmological Society. She has joined us as the MOS panelist. She's a very prolific entry segment surgeon and runs a large-scale Anil Eye Hospital, which has a legacy of more than 50 years. So welcome, Dr. Anaga.
Thank you. Thank you. Great, amazing webinar. Absolutely amazing.
And we also are joined by Dr. Aditi Vatve, who is the secretary of the scientific committee of the Maharashtra Ophthalmological Society. She is an oculoplasty specialist trained at LVPI, and she currently practices in Kolhapur. Welcome, Aditi.
Hi, thank you.
So now we will be starting the second session, which is equally important. Now we are going to build with the diagnostics. And the first topic is going to be the errors that we all have for the angle assessment. And we all know that we have looked at the gonioscopy. We have looked at how the angle assessment has to be done clinically. But what we are going to look at now is that the angle assessment is looked at from the diagnostic point of view with the help of ASOCT and UBM. What are the common mistakes which are done for that? And we have Dr. Vidya Chalrekar, who is going to speak to us about it. Dr. Vidya is having a glaucoma practicing experience of more than 20 years. She's been trained at both Arvind Eye Hospital as well as the LV Prasad Eye Institute, and currently heads the Department of Glaucoma at the HV Desai Eye Hospital in Pune. So thank you, and over to you, Dr. Vidya. Thank you.
Thank you, Dr. Vardhaman. I'll be now sharing the screen. So is my screen visible?
Yes.
Yeah. So, good evening. I thank the MOS and the organizers, Dr. Vardhaman and Preeti, for inviting me for this webinar. I will be talking about the mistakes or shortcomings in angle assessment using the ASOCT and UBM. Of course, the most important challenges with the anterior segment imaging are availability, cost, and interpretation. However, there can be some mistakes that can be, or drawbacks that we can have with the ASOCT or UBM, and let us look at few of them. Some are technical issues. The operator has to be familiar with the specific machine functioning and the various scan protocols. And it is also helpful when the operator knows what the clinical situation is for which we have ordered the ASOCT, so that he can obtain the correct image using a proper technique. Image acquisition can also have some difficulties. So image quality from the superior and inferior quadrants of the angle is suboptimal due to interference from the eyelids. So images that are not acquired perpendicular to the ocular surface may be distorted. You can see some of the examples on the right side. So there can be certain artifacts. A poorly aligned scan or poor penetration can be there when there is some opacification. The ASOCT is not equipped with an objective scoring system like the signal strength, the way we have it in the posterior segment OCT. And the observer is left to subjectively determine the quality of images. And the quality of images finally definitely affects the measurements. So regarding subjectivity, there is a good intra and inter-observer reproducibility in the nasal and temporal quadrants, but more variation is found in the inferior quadrants. The room lighting conditions also affect the scan. They may affect the pupil size, and it is important to maintain the same conditions over multiple visits so that the images can be compared. So the most important challenge. Okay. The most important challenge is identification of the landmarks. The scleral spur is the most important landmarks, which serves as a surrogate for the trabecular meshwork, and it is critical to calculate the various angle parameters. Sakata et al. In their study found that accurately locating the scleral spur was possible only in 72% of the images. And limitations in the visibility of the scleral spur and wide variation in the angle anatomy in the normal eyes may limit the routine of quantitative measurements for angle assessment. So as you can see on the right side, there are various pictures that I have collected. The scleral spur is not always easy to locate, and that may affect the further measurements. Currently, there is no technology available to automatically identify the scleral spur. The quantitative parameters are known, but there are no clear guidelines as to how to manage patients based on these values. There is no inbuilt progression analysis, and hence there is a lack of tracking between visits. Another drawback is inability of the ASOCT to visualize structures posterior to the iris because of poor penetration of the iris pigment epithelium. And this limits its application in understanding the secondary causes of angle closure, like a plateau iris, ciliary body cyst, cyclodialysis. Any ciliary body pathology cannot be identified with the ASOCT. With the UBM also, there are certain disadvantages. It is a contact procedure and there is a need for immersion bath. Patient has to be in supine position. There is a need for a skilled examiner, and it takes a little longer time to acquire the images. Of course, it has a high cost and limited availability. There is a lesser image resolution in the UBM as compared to ASOCT, but the greatest advantage it has that it is able to image structures posterior to the iris. There is good intra-observer reproducibility, but poor inter-observer reproducibility, probably again attributed to the manual identification of the scleral spur. So how does anterior segment imaging compare with gonioscopy? Gonioscopy is a rapid tool which allows 360-degree assessment of the angle. Indentation is possible with gonioscopy, which can reveal more information regarding the pathology in the angle. It is definitely less expensive than the anterior segment imaging devices, and hopefully it is very easily available with all the practitioners. So the basic difference between the two technologies is in the definition of angle closure. With gonioscopy, it is inability to visualize the posterior trabecular meshwork. With the ASOCT, it is iridotrabecular contact. So again, Sakata et al. Compared performance of gonioscopy and ASOCT in detecting angle closure in different quadrants of the eye. And they found that the ASOCT tended to detect more closed angles than gonioscopy, particularly in the superior and inferior quadrants. So though we have certain studies in favor of ASOCT showing good sensitivity for detecting angle closure, we still do not know how to use this data for clinical practice. More studies are needed, hence, to determine the utility of ASOCT. And longitudinal studies are required to determine the significance of eyes classified as closed on ASOCT but open on gonioscopy. So hence, ASOCT is not yet able to replace gonioscopy, which still remains the gold standard. Thank you.
Thank you so much, ma'am. I think this was a very nice overview, especially for general ophthalmologists. We all know that, I think with the advent of OCT being commonly now available with all the anterior segment surgeons, and many of them have the attachment for the ASOCT as well. But I think your remark about the gonioscopy still being the gold standard, it is resounding, let's say, principle for everybody to go back and learn gonioscopy in the right way, rather than just going and relying on ASOCT skills. So thank you, ma'am, for a very, very comprehensive overview of this topic. Thank you again.
Thank you.
Yes. So after this wonderful talk on the ASOCT and the UBM mistakes, Now we have a very pertinent topic, one of the most important topics of today, which is the mistakes in the perimetry. And I think this is extremely relevant. And to cover this, we have Dr. Murli Ariga. He is a glaucoma specialist with a large experience practicing in Chennai at Swami Eye Hospital. So over to you, Dr. Murli, for your presentation. Thank you.
Is he muted?
We are not able to hear you, Dr. Murli.
Dr. Murli?
Can you unmute yourself?
I thought I did.
Yeah.
Now you are audible.
Yes.
Yeah, it's okay now?
Yes.
Yes, thank you.
Okay, yeah. So pearls and pitfalls. I've slightly modified the topic to say pearls and pitfalls. And as you can see in the slide here, for a good perimetry, you need to have a calibrated machine. You need to have proper instruction, which is given to the patient. You need to have a perimetrist who doesn't wander off, has a cup of tea and looks at the mobile. And you should also have an ophthalmologist who actually interprets the field in a systematic way. Checklist, you look at the reliability of the field, false positive, false negative, and fixation loss. The pupil size is very important, refraction and near correction. And of course, the learning curve, that patient doing it for the first time definitely needs a couple of tests before they get familiar with the test. So you do this zone-wise interpretation, which has been famously taught by Ravi Thomas, and thereafter many, many other publications and talks, that you need to look at it systematically, look at patient data, look at all the available parameters, which is the reliability, zone 3, the zone 4, and all that. I'm not going to go into the details, but it's available in many publications as to how we should systematically interpret the visual field. The trial lens placement has to be kept properly, patient positioned well. It has to be full aperture lens, centered well, so to avoid these rim artifacts of the trial lens. And the pupil size also should be a minimum of about 3.5 millimeters. Anything less would definitely cause the meiosis effect, and anything you will do a different diameters every time, you can have varying thresholds. You can do dilated, but there's no contraindication of dilatation, but dilated pupil should be repeated with the same dilated field every time. Eyelid artifacts with ptosis, blepharoptosis, and so on, all this can affect the field, and you get artifacts like this. If you want to decide how much of the field to test in any given patient, we know that the central 30-degree covers a lot of the visual cortex, and therefore it's enough most of the time. But 30-2, you can actually sort of, according to the Anderson's criteria, you may ignore the edge points, but if you ignore edge points in the 24-2, you will find the example in the slide which I'm showing you here. If you ignore edge points, it is at your own peril. So don't ignore edge points in 24-2, whereas in the 30-2, you may actually ignore edge points. If you're having an advanced field defect with a defect close to fixation, you should look at the central field, do a 10-2, because you test it closer, 68 points, 2 degrees apart. Therefore, 10-2 definitely useful. Suppose your field is normal, but you have an RNF field defect, the field is not showing it. We used to do what is called as a 10-2 field. It will actually show up the field defect. The 10-2, at some points, the 10-2 have been incorporated in the 24-2. It is now called 24-2C in the newer machines. So testing strategies, most often we will do what is called as efficient threshold, which is theta standard or the dynamic in the octopus perimeter, the theta fast or the top perimeter. You wouldn't do supra threshold, you would not do full threshold nowadays, because this is not a efficient testing. If you look at the field test, if you can do full threshold 14 minutes, you can actually do a theta fast in about 3 minutes and so on. So, but the theta standard remains the gold standard, and maybe you should do a 24-2 or 30-2 test theta, which is the default which the machine will now perform. Theta faster is also available, which sort of makes the test quicker and therefore improves the patient's performance and so on. Reliability is very important. You need to keep looking at the fixation loss in particular. Suppose the patient does not do it well, you re-instruct the patient, reinforce, do a demo, and make sure you get a good functional test out of the patient. Repeating a test is definitely useful. You will find that there's a definite learning curve. False negatives need not be ignored in every patient. False negative generally means that in advanced glaucomas like this, you can have false negatives. So not all false negatives like this are unreliable. So is the field abnormal or not? This is the famous Anderson's criteria. We all know this. So the cluster of 3 or more non-H points, the PSD what occurs in less than 5%, and the GST being abnormal. These are all the criteria for abnormality. But is it glaucoma or not is very important. If the field is abnormal, follows an arcuate pattern to the pattern corresponding to the nerve fiber layer loss, asymmetrical across the horizontal, located in the mid periphery, 5 to 25 degrees of fixation, and is reproducible and not attributable to any other pathology, usually clustered or localized to neighboring test points, should correlate with the appearance of the optic disc, and does not affect the visual acuity except in very advanced glaucoma or the presence of cataract. So just being abnormal field is not enough. You have to correlate with all whatever you see in the patient and then decide is it glaucoma or not. So look at this typical example of a field defect. We sometimes miss this subtle RNFL defect and this defect in the notch in the rim. You can actually go back and look at the optic disc once you encounter such a field like this. You go back and look at it, you will definitely find it there. Usually a structure function correlation is ideal and you have to really look for it. So these kind of field defects are very typical. Even an MBBS graduate could tell you that this field is neurological and there is something going on with the hemianoptic pattern. But the bilateral symmetrical field loss like this is sometimes missed. So what you should do is keep the field side by side, keep both the right and the left eye field, especially if you're having symmetrical field loss. You can easily miss this quadrant anopias, pie in the sky and pie in the floor kind of defects. So be it suspicion that this is abnormal and think of neuroimaging and when the intraocular pressure is normal and there's a vision loss or some neurological signs and symptoms, don't hesitate to image or don't hesitate to refer to neuro-ophthalmologist for further evaluation. And we all know lastly that structural changes usually precede functional field defects, but not always. You look at this example of fields being normal, the RNFL defect being there. You can't do a 10-2 or do the 24-2C. And this is the typical example of the continuum which Robert Weinreb has described, that field changes usually don't occur until late in the disease and so on. It is not always true. And we know from various studies that field defects can sometimes precede structural changes and so on. So don't go with the dogmatic rule that structural changes always precede functional defects and so on. I thank you all for your attention.
Yeah. Thank you so much, Dr. Murli, for such a nice overview and the both pearls as well as the pitfalls about perimetry. And I think your important message about the structural and functional correlation really is important, because I think that is something that we have to keep the whole picture in front of us rather than looking at only one test in isolation. So thank you again for a very nice and comprehensive talk. Thank you.
Thank you, Vardaman. Thank you.
And now next, as we have spoken about the functional correlation, we are going to go back to the structure and we are going to have a nice overview about the mistakes that we do in actually evaluating the OCT. I believe it is going to be mainly the disc evaluation of the OCT by Dr. Ajit Hazari sir. Dr. Hazari sir is a glaucoma specialist practicing in Aurangabad. Since last 20 years, he has been trained at LV Prasad Eye Institute as a comprehensive ophthalmology fellow with special interest in glaucoma. He is a prolific anterior segment and glaucoma specialist, and we are looking forward to learn from you. Thank you.
Thank you, Vardhaman. And that was a great talk by Murli and makes my job so much easier. So I'll carry forward from there and start with sharing my screen. Yeah, is my screen visible?
Yes.
Is it visible?
Yes, yes.
Okay, great. So OCT machines have become so common even in the interiors of the whole country. So many practitioners have OCT available, and almost every town or every city would be having access to OCT. Yeah, so the OCT data is a treasure house of information. It is simple to use and interpret in the vast majority of obvious glaucoma cases. But the challenge remains that it is difficult to rely on its information in situations of glaucoma suspect, early disease and progression analysis, especially for advanced glaucomas. There it becomes tricky and needs careful evaluation of the data that is presented to us. So if we look at the errors which contribute to the mistakes that happen while doing OCT or evaluating OCT, they are the operator errors, patient errors, patient pathologies which interfere with the data, software errors, and finally the clinical interpretation errors. When we are evaluating the OCT printout, there are typical errors or mistakes that we can do. And these also can be classified as clinical decisions based on poor quality OCT scans, or clinical decisions based on a single OCT scan, or extrapolating results from a machine of one make to another, where it's very difficult to compare the data from one make to the other. And OCT, RNFL, as well as GCA defects seen in healthy eyes, and this happens in about 5% of the healthy eyes. OCT defects that are not seen in eyes that have glaucoma. So we are talking about an apparently normal OCT test result where the patient has been already diagnosed to have glaucoma. And the final, if time permits, we'll also talk about quadrant average maps versus clock hour maps. So if we talk about the poor image quality, data entry is an obvious one. So I won't go into that. But one common thing that I've seen, especially with people who have not been so experienced with using OCT machines, is that the misalignment of the scan circle around the disk. And for example, on the upper right corner of the screen, you see a strip of images where you have a misaligned scan circle, and that presents us an inferior large RNFL defect as well as a small superior RNFL defect. And this patient was referred to me based on this scan for further management of glaucoma. So when we redid the OCT for this patient, and we did a well-centered scan, and lo and behold, that the RNFL defect disappeared. At the edge of this TISNET map, you see that the reading is going up towards the sky, and that's because of the ERM that the patient had. The other common mistake that happens is poor patient positioning at the machine results in an uncomfortable patient and a result in poor image quality. So we need to be careful about making the patient comfortable when the test is being done. Going further into poor image quality analysis, if we are doing OCT after lots of other tests have already been done on the patient's eye, then it can result in a dry surface which can affect the image quality. If it's a small pupil along with a cataract, again, that would affect the image quality. Media opacities like cataract, dense vitreous floaters, they cast shadows on the retina, like you see in the example on the upper right side, and this leads to missing data and wrong interpretation. Blink artifacts, like the one you see at the bottom right, are because the patient is uncomfortable and is blinking, and that again leads to missing data on the scan. Vitreoretinal interface abnormalities like VMT or ERM leads to overestimation of retinal thickness and abnormal patterns. If it's a slow machine or an uncooperative patient, you also get motion artifacts. Motion artifacts become important when you're doing a long-term follow-up for the patient, and you can't compare to scans because of the poor quality. If your machine is not well serviced or it's placed in a dusty area, it's likely to accumulate a lot of dust inside, and that finally will result in a lower signal strength for the OCT. And you will consistently get poor quality images. Here's an example of a vitreoretinal interface abnormality. This is in an 81-year-old pseudophakic with pseudo-exfoliation glaucoma, and there's progression seen on the RNFL scans over the last 4 or 5 years. And also on the perimetry, on the 24-2, you can see a progressively increasing field effect. But if you look at the ganglion cell layer analysis, you get data which is all over the place. It's completely confusing. And that's because of the ERM that the patient had and a gradually increasing macular thickness. So when you're looking at these scans, you need to look at all the data that's being presented to you. If you look at OCT defects, they can happen in about 5% of healthy eyes. And they're more common in high myopes, especially the ones with long axial lens. So how do you rule it out? You do
6 months, 6 minutes are over.
It's already done, huh? Oh, okay. So correlation with GCA defects is one way how you can rule out defects in healthy eyes. So, yeah, let's come to the summary, okay? And the summary is that you pay attention to the ocular surface, you pay attention to the patient's position and comfort and the media opacities that the patient may be having. Careful correlation of the retinal nerve fiber layer and ganglion cell layer analysis, and if ONH is available, with the clinical picture and perimetry. So if you consider the wholesome picture of the patient, then that will reduce the erroneous reading of OCT reports. Serial studies over a long period of time help us in picking up defects that are significant, as well as help us in picking early progression. Thank you.
Thank you very much, sir. I think it was a very nice and especially case-based manner of learning about the mistakes that we do in OCT. And I think what we have learned in all these talks are basically we have to always look at the complete picture and not only one diagnostic equipment in isolation. And at the same time, it is always important to look at the serial analysis, whether you're looking at the clinical examination of the disc or the OCT of the disc or the perimetry. Your serial analysis is very crucial, and that's especially important point for our comprehensive ophthalmologists who are treating glaucoma. So now over to you, Dr. Preeti ma'am, for the panel discussion.
So the first question is on ASOCT. That there's a difference in the way a comprehensive ophthalmologist uses an ASOCT and a glaucoma specialist uses it. A comprehensive ophthalmologist uses it as a replacement for gonioscopy, whereas a glaucoma specialist will use it to add on to his knowledge. So now there is the question to Shefali. Shefali, if a comprehensive ophthalmologist buys an ASOCT, they have no clue what they're looking into the angle. So they are relying on somebody else to tell them what they see when they are imaging. So do you think there should be a kind of a 15-day course which every machine, when you buy an ASOCT, that the operators themselves should have these buyers go and have a 15-day observation course? Shefali.
I think regarding the observation course, definitely, I think whenever you purchase any machine, it should be. But yes, like ASOCT, it is a good tool at this point of time, but definitely not, it cannot replace gonioscopy. The reason being, if you see the specificity of ASOCT, it is nearly 60-70%. That means in nearly 30 to 40% of normals, you will get the occludable angles. That means you are getting false positives. Already we are overburdened with the PSCS and PSE and PSEG. So definitely we don't want to overburden. Second thing, what Dr. Vidya said very correctly, because it is very difficult to identify the scleral spur. So that scleral spur is an important landmark. And when I am doing ASOCT, I know if I am doing in the same patient next time, I am confused where was my scleral spur. So that identification part, it is definitely, I think the company people has to have something where that identification part becomes a little bit easy. Maybe they can keep something that I feel that identification of the scleral spur is making use of ASOCT difficult. Third thing, ASOCT at this point of time, it cannot tell you where are the synechia, how many synechia are there. So what you can see in gonioscopy, which is, as everybody said, it is just not even 30-second procedure, I think. Indentation gonioscopy, so at this point of time, I will not recommend to general ophthalmologists, but to not even glaucoma specialists, to replace gonioscopy, the ASOCT for gonioscopy.
It does not replace. Yeah, Dr. Siddharth also wants to, and Rita, sorry, it was you, right?
I'm Dr. Shikha.
Oh, hi, Shikha.
Yeah. So since technology is moving forward, Heidelberg is coming up with its latest version, which has already been launched in US by the name of Antiron. It claims to automatically detect the scleral spur. and how specific and sensitive it is, we'll have to test it. The other thing is KCR OCT, which is the swept source OCT. It also gives us an ITC index, which is the iridotrabecular contact index, which tells us exactly for how many degrees quantitatively there are synechiae present. So though these are advanced tools and very expensive for individual practitioners, but these can be taken, they can be used by those in the institutional practice, and they are really a game changer in that case.
Thank you.
Only thing is whether they are reproducible or not, those findings, that needs to be still, we have to wait for that.
ITC index is pretty, we are using it, ITC index, and it is pretty reliable, yes.
Thank you,
I would
Shikha.
also
Dr.
like to say, sorry, I would also like to say that despite all of these newer investigations or improvements happening in the OCT, we are still not able to see blood vessels in the angle with the help of your ASOCT or your UVM. You are still not able to identify pigments. So there are so many things that you will miss out on. So no imaging can be a replacement for gonioscopy. I mean,
So these are
whatever
addition, not replacement. These are additional tools.
Shikha, we can have that discussion later. Dr. Siddharth, you had something to say. You unmute yourself, please. Thanks.
Sorry again. I have almost been made redundant by what Dr. Shivali said. One basic question. Can ASOCT differentiate between a patient who has PACS and PAC by the virtue of having blotchy pigments or goniosynechiae? It cannot. It cannot, therefore, differentiate even between patients who need just follow-up on a 6-monthly basis and a laser PI. So for me, the need for ASOCT to show whatever it is on the imaging lies, basically, I only do ASOCT when I'm unable to convince a patient for the need of PI on the basis of just my conversation. And then I show that patient, and it happens almost universally in a patient who has a unilateral angle closure, and I advise the patient a PI in only one eye. Then on occasions I have needed to show them an imaging, the printout, and show them the difference between the two eyes and show them that these two are different eyes and one eye needs a PI. Otherwise, if you want to use ASOCT to judge whether a patient needs a PI or not, even then it's not completely useful. It cannot differentiate between a PACS and PAC.
So the take home is ASOCT does not replace gonioscopy. One, it takes a little expertise to identify structures and diagnose angle closure on ASOCT. So those who buy ASOCT, please go and have some kind of a training how to use an ASOCT, because you just can't buy it and start using it. It requires a particular type of training. And as Dr. Siddharth says that a picture is equal to 1,000 words. So that's what he's using the ASOCT to convince the patient that please undergo PI. So
and one more thing that we must remember, that almost all the research papers, the publications that you have, are using an enhanced image from the ASOCT. So they enhance it in order to be able to identify the scleral spur and use a software to get automated measurements for publications. That is not going to happen in real life. So ASOCT in real life is far away from the ASOCT that you see in publications. ASOCT in publications is still not able to differentiate between PACS and PAC.
Thank you, Siddharth. Meda, mute yourself, please. Meda. Sorry, yeah. So now the next question is that a large defect on a perimetry anybody can identify. So how do you differentiate an early glaucoma damage from an artifact? So who we have here. Yeah, Rita, if you can just go ahead, please, and tell us. I was looking for Dr. Pradeep Vyas. I don't know if he's there.
He must be there.
Dr.
Anyway.
Pradeep Vyas, Dr.
Very
Rita,
much,
and then
very,
Dr.
very
Pradeep.
much.
Yeah, if
No,
you
no, let
can.
Pratik take it on the Pratik. I'll speak later. I'll be talking too much.
Yeah, Dr. Pradeep, please, if you can, how will you differentiate an early glaucomatous damage from an artifact?
Okay, so in the early glaucomatous damage, you will have a generalized reduction in the sensitivity. So if you have a generalized reduction in the sensitivity, which is going probably more than 4 decibel, 5 decibel, 6 decibel, then yes, you can call it as an early glaucomatous defect. While in the artifact, you will get some defect here and there, and which you won't be able to explain on the basis of your clinical evaluation of the optic nerve and the RNFL. So that is how you can differentiate between the early glaucomatous defect and the artifact.
Thank you, Dr. Pradeep. Rita, you want to say?
Now, I think you have to see whether your defect, whatever defect you are seeing, whether it is actually correlating with what you are seeing on your disc. If it doesn't correlate, then you just ignore that defect for the time being. Repeat the perimetry, because when you repeat the perimetry, if that defect is reproducible, then you know that it was probably not an artifact, but it was a real existing defect. Having said that, another thing that I would actually like to bring to notice is that learning curves are not really just just done by one field or two fields. Sometimes you have patients who have learning defects for years on end, and in those patients, I think it's really difficult to get to do a perimetry. So that's my input on the early defects of perimetry.
So one is, if it does not correlate clinically, then it may be an artifact. And second is, when in doubt, repeat. Okay.
Correct.
So that should be. So now we go to the OCT. Now, Dr. Siddharth, how often have you advised surgery based on OCT changes? Because we see patients who are advised your glaucoma has progressed, we should do a trap. So how often in your practice have you advised surgery based on OCT?
Never in my life have I ever advised surgery on the basis of OCT. And I can tell you for sure that at LV Prasad Eye Institute, right now, I'm the person who uses OCT the most. So one has to remember two things. One is that the trabeculectomy or whatever surgery you perform is aimed at reducing the intraocular pressure. And OCT, with its highest sensitivity, is detecting changes in RNFL thickness or the GCL map, which detects the thickness of the RNFL at the macula, which is hypersensitive in my belief. So I don't take OCT for advising surgery. If I have to advise surgery, I have to corroborate the progression on OCT with HVF at the best specificity or the intraocular pressure at the best sensitivity. So if it's a patient with a glaucoma who has progressed continuously on OCT, I would not be against advising surgery. So you have 5 OCTs and the patient has shown continuous progression on OCT, I will go for surgery if the patient is on maximal medical therapy. If the patient is on one drug and the patient has shown progression on OCT, I would not be resistant to advising one more drug, because even the GCA, the WGC committee has agreed on the fact that OCT is far more sensitive for detecting progression than its sensitivity in comparing in diagnosing glaucoma. So progression on OCT has to be taken seriously, but it has to be done in collaboration with other things.
So just 1 minute, what Siddharth has said. I agree fully. Only thing is Siddharth is talking about progression, but I just want to send one message overboard because we have seen patients who have been advised surgery based only on OCT and there is no clinical correlation. So I think that clinical correlation is the most important part. We have seen people who has been advised surgeries, trabeculectomy with absolutely normal optic disc. So I think that message has to go overboard. Based only on OCT, it is no, total no. Forget about progression. That comes very much after, but based only on OCT, we should not advise any surgery.
So I would say a message for the comprehensive ophthalmologist is OCT is an adjunct to your clinical acumen, your clinical findings. Based only on OCT, you can never advise surgery, and that's what I wanted to get across. So if we can now, Vardhaman, we can go on to the next session.
And just one more comment.
Dr. Siddharth, yes.
And patients who are on the verge of surgery, they probably already have a floor effect of OCT. Any advanced glaucoma, any patient with mean deviation greater than minus or worse than minus 12 decibels, OCT is useless. There
So
you cannot
OCT
depend upon OCT.
So early and mild and moderate glaucoma, OCT still has a role to play, but not in advanced glaucoma. So with that, I think we can go on to the next session. Vardhaman,
Thank you, ma'am. I think a lot of amazing pearls learned in the last session and also from our expert from panel discussion. Thank you, Dr. Preeti, ma'am, and all the experts. Now we have diagnosed that the patient truly has glaucoma. And now, of course, a comprehensive ophthalmologist as well as a glaucoma specialist would like to start him on a medical treatment. And so we have to look at what are the common mistakes that are done when you initiate a glaucoma therapy. And to talk about it, we have Dr. Meda Prabhudesai, ma'am. Mrs. Prabhudesai is the medical director at Prabhudesai Eye Clinic, unit of Agarwal's Eye Hospital at Pune. She's been having experience of treating glaucoma over 30 years. She's trained at the prestigious Shankar Netralaya and has been also glaucoma consultant in the past at Sri Ganpati Netralaya before starting Prabhudesai Eye Clinic. Over to you, Dr. Meda, ma'am, for your topic, which is mistakes in initiating therapy, medical therapy.
Thank you, Vardhaman. I would like to thank MOS for inviting me for this. And there are a few things I would like to add. Just 1 minute. Let's start. Yes. Is my screen visible?
It's visible.
See, I'm going to talk on mistakes in initiating medical treatment. Before I start, I would like to announce that 32nd annual conference of GISI is now going to be held in Pune. So you need to save these dates. The registration link would be open maybe tomorrow onwards, and you can use the Super Saver rates for registration. So coming to mistakes in medical management, I know many of us have seen prescriptions like this. So 48-year-old male patient came with high pressure. There were no investigations. Patient also had history of COVID pneumonia, and patient has been using prescription like this. It looks like the Canfort is one molecule, Combigan is one molecule, but we know that it's not like that. So patient is using prostaglandin 3 times, beta blocker 4 times, and all these things. So this is a major mistake that everyone should avoid. So what are the anomalies in drug choice? This was done as a retrospective study, and anomaly was described as prescription of 2 new drugs simultaneously for initiating treatment, prescription of a new drug without considering non-adherence of the patient, prescription to unorthodox drug frequency, so beta blockers 3 times and all those things, and prescription of a contraindicated drug was considered as error. So this is prescribing errors. This is another study. They were almost 18%. So what are the prescribing errors? So most important is wrong diagnosis, which we are discussing till now, wrong drug, wrong dose and route, wrong frequency of the drug, and obviously wrong time. So wrong diagnosis or overdiagnosis is based on what we discussed now, is based on one single high IOP reading. First, abnormal visual field, abnormal OCT, and without evaluating the patient properly. So high IOP reading, we know that OATS has shown that low risk group do not progress to POSG, and we should avoid that. Also, we should consider thick CCT can have high IOPs without considering for individual target IOP based on this diagram, which EGS has provided. That is glaucomatous damage, life expectancy, untreated IOP, additional risk factors, and considering the rate of progression. Not following standard protocols that you have to start with one molecule. And if it is effective, you need to continue. If it is effective, but the target IOP is not reached, you need to add. And if it is not effective, we need to switch. Starting therapy on first abnormal visual field. This can be something else and not glaucoma. So you need to see the fundus very clearly. Starting therapy based on only abnormal OCT. Like this, the patient has a posterior polar and PSC cataract, and so this patient definitely is not a glaucoma. Patient already has a moderate myopia with tilted disc. Starting therapy based on correlation between OCT and visual field. So patient was already operated when he came to me, and if you look at the field and this, it correlates. But if you see this is the defect is because of the BRVO and the laser which was done for this. Not recognizing the angle closure. Pressure is high, you don't do gonioscopy and start treatment based only on pressure without doing gonioscopy, which we were discussing till now. So not recognizing a neurological visual field defect. Patient might be harboring something and you think that this is a glaucomatous field and start treatment for that. The another thing is that the wrong drug. So starting treatment without proper ophthalmic and systemic history. Beta blockers in a patient with asthma and COPD. Brimonidine is contraindicated in patients less than 2 years. Prostaglandins in uveitic glaucoma and patients with herpetic keratitis. Cholinergics in uveitic glaucoma and angle recession because there can be paradoxical rise in pressure. And eye drops with preservatives in patients with allergy and dry eyes. Use of contraindicated drugs in pregnancy without asking and lactation without asking proper history for a juvenile glaucoma or young patients, females with glaucoma. And these drugs need to be avoided. Wrong frequency, I've seen beta blockers used thrice a day also, or sometimes only at night, once in a time. Sometimes prostaglandins have been used twice a day, and do not obviously use 2 drops with same molecules in different combinations. Wrong dose and route, not writing which eye, where to put, not explaining the double dot technique, and writing only E/D, so that is for eye drops. So don't do that. Not mentioning duration of the medicine, that you have to use the medicine till next follow-up at least. Not writing the day of the visit that they have to put the drops. So patient says that, oh, I used 1 bottle and not using now, my bottle got over, so I didn't know that I have to put. So these things should be avoided. Compliance and adherence. So presuming that patient is using drops properly, not giving instructions about possible side effects and allergies of individual drops. We know that great IOP lowering medications don't work because patients don't use them properly. And patient decides himself what to use and when to stop. So you need to consider all these factors, patient characteristics, that is safety, systemic, as well as ocular, adherence, and quality of life, and drug properties, that is efficacy, target IOP, preserved and unpreserved drops, and as well as cost
6
of the
minutes are
medication.
over.
Yeah, last slide. So according to European Glaucoma Society guidelines, it is unlikely that more than 2 pharmacological preparations with maximum of 3 active molecules are going to be additive, effective, or well tolerated and reliably taken by the patient. So we need to keep this into mind. And thank you for your patient hearing.
Thank you, ma'am. I think this was a very clear-cut guideline and very precise presentation. And I'm sure many take-home messages for our delegates who are listening to our webinar. Thank you for putting up all these wonderful points together as pearls of wisdom.
Thank you. Thank you, Vardhaman.
Thank you. Next, once we have initiated the therapy, of course, the mistake which is common is analyzing the progression. In spite of putting them on the initial therapy, And to talk about the mistakes in progression analysis in the RNFL, we are going to have Dr. Vinay Nangia sir. As we all know, Dr. Vinay Nangia sir has been the past president of the Glaucoma Society of India. He is the founder director of Suraj Eye Institute, which is a large-scale research institute and also postgraduate institute of training. Sir has more than 170 international publications and is a prolific researcher trained at both Shankar Nethralaya as well as in the UK and also at Boston at Harvard University. So over to you, sir, for your talk. Thank you.
You're not audible.
Sir, you are not audible, yeah.
Yeah. Can you unmute yourself?
Yeah, I've done that.
Yeah.
So I'm going to talk to you about mistakes while assessing progression with the retinal nerve fiber layer. And the retinal nerve fiber layer imaging has been essential for several years in the assessment of glaucoma. And the OCT enables high quality imaging, and algorithmic tools enable the segmentation of the retinal nerve fiber layer, allowing measurements across at each point. And detecting structural change over time helps diagnose glaucoma and its management by setting target pressures and deciding the treatment modality. The average change that is considered to be acceptable for average global retinal nerve fiber layer thickness is a change of 4 to 5 microns for glaucoma progression over time. And because of the lower reproducibility of sectorial compared with the average global retinal nerve fiber layer thickness, a relatively more significant change would be needed in sectors for similar confidence of actual change. And that's considered to be approximately 7 microns, I beg your pardon, it's not millimeters, 7 microns and 8 microns for the temporal nasal sector. And there are a few good papers that suggested that the average loss of retinal nerve fiber layer was about 0.52 microns. For superior segments, it was minus 1.35 microns, and the inferior RNFL loss was minus 1.25 microns per year. But this study was done only over a period of 30 years. But what it suggests is that one should tread with caution if there is a statistically significant slope of less than 0.05 with p-value, and about 25% of normal eyes may be shown to have this change over 5 years. And therefore, the trend-based analysis of RNFL thickness change should involve testing the statistical significance of its change relative to the estimate of age-related changes, so that you're differentiating between the two and you're not making mistakes and calling a normal patient as a glaucoma patient or glaucoma suspect as a glaucoma patient, actually. So I'm going to take you through a few case reports of when you have difficulty in assessing the progression. And if you just pay attention to the blue arrows and to the dates for each of the scans. So if you take a look at the top scan, blue arrow, you'll see that the red and blue lines have joined up actually. And that is a very common segmentation error. And if you go to the scan below, you'll see that the blue arrow shows you that if the two lines join, then really you're not going to get any readings for the retinal nerve fiber layer. And the point is that the two lines have joined at a place that is very, very susceptible. It's one of the most susceptible areas for glaucomatous damage that can occur very early on, and that leads to loss of inferior ganglion cells. So you need to be cautious about looking at the segmentation. This is, of course, a patient that really has burnt out optic discs, but I just wanted to show this. If you take a look at the scan on top, the blue arrow tells you that the segmentation is not very good at the superior-temporal this thing, and it's going far beyond the retinal nerve fiber layer, encroaching into the outer nuclear layer, and therefore it gives you a big peak actually. But when you go and see the bottom right scan that was done in 23, you'll find that the black line shows you that as if the retinal nerve fiber layer has decreased, but it may not have decreased. It's just that the initial scanning, the initial segmentation was not very right actually. And again, this is a case of segmentation error that causes that you must pay attention to before you identify someone with progression. And this is another patient, and the blue arrow on the top right shows you that there is epiretinal membrane. And when you have an epiretinal membrane and it begins to separate from the surface of the retinal nerve fiber layer, then you get increased thickness of the retinal nerve fiber layer. In this case, of course, it doesn't matter too much because the increase in thickness is very mild and it's nasally located, and you won't consider that too much. But when you take a look at this patient, where there is a significant epiretinal membrane, you'll find that in the top right, the segmentation, it's actually the machine somehow segmented out the epiretinal membrane. But when you go to the second scan that's done on 27/1/23, you'll find that the machine forgot what it had done earlier. And this time it included the surface of the epiretinal membrane in the scan, and then you will get difference in thickness. As you can see in the round circle that is divided into sectors, that it's all red in the superior scan, and in the inferior scan, it actually appears to have improved, but really nothing has changed in this patient. And this is another patient where you find that this is a segmentation error that often takes place when there is a flattening of the retinal nerve fiber layer. It sort of bottoms out, the flooring effect. And this is a time when maximum errors take place. And if you take a look at the scan on the left side, you'll find that the deeper part of the blood vessels, it's not been included in the segmentation of the retinal nerve fiber layer. But when you take a look at the scan done in 2020, you'll find that somehow the machine has included a larger part of the inferior part of the blood vessels, in the scan. And therefore, you get the sensation as if that there is thickening. And this is retinoschisis of retinal nerve fiber layer. The top right shows you the retinoschisis, and it can cause an artifactual thickening. And if you look at the bottom scan, yes, the retinoschisis actually resolved by itself, and that is known to happen. And the retinal nerve fiber layer thickness has decreased actually. And so significant optic disc cupping will often lead to segmentation errors. You may still wish to assess the OCT to follow up on the macular RNFL, which then becomes the most important segment. Epiretinal membranes and retinoschisis are a source of errors. Myelination is also another source of segmentation error. Poor vision and inability to fixate must be considered. And always look at the different images and images without the segmentation to get a clinical impression of the accuracy of segmentation and the health of RNFL. Thank you very much, all of you.
Thank you very much, sir, for such a nice overview, and especially to do this in a case-based manner. And I think the point that you have tried to emphasize is there are so many retinal conditions which, let's say, create a bias in our analysis of the OCT, especially for the RNFL progression analysis. It is very important that we have to always keep the clinical picture in front of us when we look at the progression. So thank you for your great overview about the RNFL progression mistakes that we all make. So friends, the next talk is going to be about a very important topic. We all know that many of our glaucoma patients do face drug intolerance. And when we face this issue, we probably don't know how to deal with it. We make mistakes very often. And to talk about this important topic, we have Dr. Pankaj Bendale from Pune. Dr. Pankaj is a glaucoma specialist practicing at NIO in Pune. He's done his fellowship in glaucoma from the Arvind Eye Hospital and has a great amount of experience in treating both medical and surgical glaucoma patients. Over to you, Dr. Pankaj. Thank you.
Yes, yeah. Thank you, MS, and thank you, Vardhaman. I think I'm audible.
Yes, you are.
Yes. So topic was given to me, mistakes in managing drug intolerance. I think this is a common scenario that we see. Yes. So I think I will straight go to the point. I think some of the points are already highlighted by Dr. Medha ma'am. So missing the culprit molecule. I think whenever patients are on polypharmacy, we don't know which is the offending molecule. So I think in my practice, whenever I lower the lower lid and I see the follicles, first thing I blame the molecule is brimodin. And out of that polypharmacy, one thing I do is I stop the brimodin or any combination that is containing it. I give mild steroids for 7 days, and that most of the time suffices, and I choose the alternative molecule whenever there are choices are available. Second is ignoring the irritating ocular surface symptoms of the patients, which ultimately have effects on the compliance. So adding this tear substitute additionally gives a lot of comfort to the patients. Example, beta blockers like timolol, they cause some amount of colon anesthesia that can cause tear film difficulties and may affect clarity also, may have an effect on the compliance also. So these are kind of the symptoms which we should not ignore during the follow-up, because patients, from patient side, they are the important symptoms. When there is a polypharmacy, lot of follicular conjunctivitis is there, one thing that gets ignored is about the punctal stenosis, which again further aggravates the ocular surface disease actually. So whenever we have any kind of punctal stenosis which aggravates the ocular symptoms, surface symptoms, then take your oculoplastic colleague's opinion to take care of that punctal stenosis which can aggravate the ocular surface disease. And choose the surgical option as per the corner situation, because serious ocular surface disease are associated with low quality of life and poor compliance issues. So some of these patients, even if you jigsaw some of the molecules, if you withdraw, you start some new molecules, and still there are some issues, then I think these patients are coming close to intervention. So I think then TRAB or maybe some MIGs, which are the options available now, SLT, or some cases very disturbed ocular surface, you might have to choose the implant also as per the case basis, as per the disc status, as per the choices of molecule which are limited, and they are not sufficient, because some of the molecule which patient is allergic to, you have to withdraw, and limited molecules, if they are not achieving target IOP, I think then this is the patient which are close to some or other form of intervention to achieve a right balance of healthy ocular surface, well-controlled glaucoma, and least disturbed quality of life. And knowing the side effect profile well for each molecule, giving importance to patient psyche, tolerance limit to mild hyperemia, and right indication, all this is important. I think Medha ma'am has very rightly highlighted all these side effects of each molecule. So drowsiness by brimonidine, some of the patients are very well, like they don't like that sleepiness, what they comes as soon as they put the morning drops of timolol brimonidine combination or brimonidine brinzolamide combination, they feel I'm drowsy, I'm not happy with that. So some of that are very important side effect which patient complains to us, and whenever this kind of drowsiness is there, someone who requires very alertness at his job, then they are not happy with this kind of molecules putting in the morning and then feeling sleepy. So give importance to all knowing the side effects of each molecule, drowsiness with brimonidine, or stinging with dorzolamide due to some acidic pH, aggravation of asthma because of beta blocker, some BROAC because of pilocarpine. So all these are known side effects, and each patient may not have tolerable limits for this kind of side effects. So remember, the damaging ocular surface reduces the chances of successful filtration surgery later. So not only we want to have a quality of life for patient and less disturbed ocular surface, I think we want to preserve the success rate of future TRABs also. So don't damage ocular surface too much by polypharmacy if patients are not tolerating that. In fact, this patient need again a lot of pre-op steroids to normalize the ocular surface. Despite that, some may have the filtration surgery getting failed early, and some of these eyes which very disturb ocular surface, TRAB fails, and within few months again we are staring at another surgical intervention like valve and all. And despite longer steroids or longer MMC application, so more disturbed ocular surface is actually taking the patient to the dead end, where then all options becomes tricky. So take care of this. So if I want to give some carry-on tips to general ophthalmologists, so don't miss brimonidine-related allergic follicular conjunctivitis is very common. I won't hesitate to say even 25 to 30% patient over a period of time, we have to withhold the brimonidine molecule for some or other reason. Avoid carbonic anhydrase inhibitors in weak endothelium cases. Avoid carbonic anhydrase inhibitors in topical sulfa allergies with chronic discharge and some kind of ocular surface symptoms patients are constantly coming. Avoid PG analogs, especially bimatoprost. Despite the severe intolerable hyperemia, then you have to withdraw that bimatoprost. Add artificial tears whenever there is already ocular surface disease. Don't ignore punctal stenosis, which will aggravate everything. Give a short-term course of topical steroids, which will stabilize the ocular surface before intervening in these eyes when surgical intervention becomes must. And choose a right treatment like any other options which are there, like advising SLT by substituting the culprit molecule, add some tear substitutes, or add surgery when we really feel molecules are limited and you are not achieving the target IOPs. Avoid beta blockers in asthmatic, COPD, or AV block cases, or PG whenever there is any inflammation in the eyes for that matter, or any risk of CME. Avoid two similar molecules in two combination. I think Medha madam has really highlighted this issue, and we all see this very commonly. Timolol being in two combination or similar group like brinzolamide plus dorzolamide given. I think these are not giving additional effects and any additive effects. So please, this kind of combination, please avoid. Avoid any wrong dosage also. And in short, avoid complex polypharmacy, which if it is disturbing ocular surface, I think it is not the way to go forward. So while treating the glaucoma, don't forget about quality of life. In severe OSD, patient feel very low, depressed and trapped, and take them out of that by substituting the irritating molecules. And if that doesn't work, then you are close to intervention. That's how you make patients more comfortable with the disease and achieve a right point of healthy control of glaucoma with a better quality of life. Thank you.
Thank you very much, Dr. Pankaj. I think it was a point-by-point, precise understanding for our delegates. And I think the thing that you have highlighted is that the ocular surface has to be preserved, because that is also going to define also the success for the future traps if it is going to be required. And I think about the intolerance, we have to be very judicious in managing them very well. So thank you again, Dr. Pankaj. Excellent talk. Thank you.
Thank you, Vardhaman again.
Over to you, Dr. Preeti ma'am, for the panel discussion. Thank you.
So my first question is to Dr. Pradeep Vyas. That what are the attributes to when you start medical management? What are the attributes in the molecule you're looking? I mean, so is it ocular blood flow? Is it neuroprotection? Is it intraocular pressure lowering effect? So what is the quality that you look for when you choose a drug to reduce the intraocular pressure?
Preeti, if you want me to make it very simplified, then I would not like to discuss about the vascular supply or the neuroprotection while considering the drug for my patient. My only consideration would be, number one, what is the damaging IOP? That is the IOP at the presentation. Number two, what is my target IOP? And what kind of a damage patient has got, whether it's a mild, moderate, or severe. And the third and the most important is which are the drugs, what are the drugs which are contraindicated in that particular patients. So based on these three things, I will select the molecule for my patient. And in my most of the patient, I select the prostaglandin analog as a first line therapy, and followed by the beta blocker, and then the carbonic anhydrase inhibitor and alpha-2 agonist and follows.
Thank you so much, Dr. Vyas, for bringing it out, because we see patients, say normal tension glaucoma patients, who are started on, say, brimonidine because of their neuroprotective effect. So my message to the comprehensive ophthalmologist is the only property you have to look at is the IOP lowering potential of that medication. So that's one thing. Dr. Rita, do you have anything to add to it? What is the attribute that you look for? Rita, is she there?
Madam, you have to unmute yourself.
Yeah, unmute yourself, please. Rita.
I'm sorry. I'm so sorry. Obviously, we look at the efficacy of the drug in terms of IOP lowering, and also at the same time, we try to see if the ocular surface is going to tolerate the medication that we are giving. Because many times before starting medication, if you have already noticed that our patients are very old and they already have some amount of dryness of the eye, if you can give them to start with a medication which is preservative free or which is tear film friendly, then I think that is what I would look at. I don't think neuroprotection or what is you say?
Ocular blood flow.
Basal, because that is ocular blood flow is something that is, yes, existing, but I don't think that any drug at present can help modify that. We know that the only thing that we are looking at in drugs is at their efficacy.
So, Shefali, now many times we see patients are not started on PG analogs, citing cost. So what is your take on it? And they are started on other molecules, so the cost is one factor. So what do you say on it?
So I think this answer is in relation with that previous one also, because whenever you are choosing your first line of therapy, so you have to be very, very careful, because all these drugs causes percentage reduction from the baseline. Now, just to give an example, suppose now that you are discussing about the cost, that is coming to second part, like whether that is brand versus generic, that is a long topic. But only this thing that these drugs, what we need to remember, they cause percentage reduction from the baseline. Suppose, just to give an example, if I have 30-32 pressure, I want around 17-18. If I start beta blocker, thinking that, okay, this is cheap, patient can afford, but we know the beta blocker, it will cause only 20-25% percentage reduction. So my pressure will come down to say around 23-24. Then I want 17-18. That means I want more pressure reduction. I have to add one more medication. Now this pressure becomes the baseline pressure for my second line of drug. On the other hand, and that second line of drug will give less percentage reduction. That amount of total reduction will be less. On the other hand, if I had chosen prostaglandin analog as a first line of therapy to begin with, and we know that it gives around 35-37% IOP reduction, so maybe with one medication would have been enough to reach my target intraocular pressure. That is one thing that we have to see what is your target IOP, what Dr. Pradeep said so that is one thing. And second, what we were discussing about the cost issue. So actually I have done a little study because it is a big, huge topic regarding brand versus generic, because mostly if you see it is a normal, that this thing that brand is costly. But even if you see the pure good generics today, they are at par with the pure brands also. And if you see the difference between brand versus generic, brand, the amount of the particulate matter or contamination is always more in generic compared to the brands. Plus whatever it is written on the labels, that it always contains the less amount of this medication. Plus generics, they never have to prove their efficacy. Once it is reducing IOP, if it is meant for reducing IOP, then it is well taken as that, okay, it is for this, but they don't have to prove efficacy, what the brand has to do. So brand already have spent a lot of money while doing their research purpose. Plus, there's always, if you see this generic, there is always a lot of wastage. I have done short study where actually the generic same, in one eye I started brand and other I started the generic. What we found, the generic, it used to last up to the 19 days compared to the brand, which was lasting for nearly 32 to 35 days. So actually, if you see the cost-wise, I always counsel my patient, whenever they see that, okay, this is costly medication, I always counsel my patient, if you take good brand, and if you're putting it properly, and you explain to the patient how to put only one drop, how to, and punctal block and everything, then what I feel, most of the time, brand is as cost-wise, it comes at par with the cheaper medication also. That is I personally feel. But still, having said that, yes, generics or maybe the low cost, they definitely have a role. But first thing, we must look for the efficacy. Like where I have to give prostaglandin, I have to give that, even it is costly, maybe you can lose a little bit cheaper version.
So the take-home message which I wanted to give to a comprehensive ophthalmologist is, one is, choose the medication based only on their IOP lowering effect, and of course any contraindications,
yes,
and contraindications which are there, that.
Yes,
The second thing is that by giving a cheaper medication, I'm not talking about generics or I'm not talking about multinationals, I'm talking about the pure cost. Even if so, there are good companies and there are bad companies. They can be multinationals, they can be Indian companies. So you choose companies which you feel are giving a good effect, and then accordingly you can give a drug. Prostaglandin analogs still turn out to be cheaper than any of the brimonidine or the brinzolamide, or because they still are 450 rupees a bottle and they are twice a day. They don't last for a month. So cost is no longer a factor which prevents you from giving prostaglandin analogs. Now, as Dr. Siddharth, if a person has allergy to a medication, how would you proceed?
Oh, yeah. The allergy, specifically for brimonidine, it manifests as contact dermatitis. Then there is no option. You have to stop brimonidine. On many other occasions, you have papillae, which manifests as allergy to the medication. And when it is very difficult to differentiate between whether it's an allergy to the molecule itself or the preservative. So then the next step for me, especially with the spectrum of glaucomas that we see very advanced, where we cannot afford a drop in intraocular pressure control, is to shift to a preservative-free combination. And I can tell you what is that with certain brands of preservative-free medications, which claim that they can be used for 2 months, they have actually been delivering. And they turn out to be cheaper than many of the preservative inclusive original molecules. So that's my next step. And if they still continue to show allergy to a particular molecule, then I replace the molecule that I think is the likely candidate for the allergy. In terms of molecules, I would say the alpha agonists, followed by prostaglandin analogs, followed by carbonic anhydrase inhibitors, followed by beta blockers are the most likely candidates. So I would say that that is the order that I would like to proceed upon.
Now, patient. So one thing is, if a person is allergic to a medication, say brimonidine, you have to stop it. Am I right? You cannot.
Of course.
Yeah, because we see patients in whom lubricating eye drops are given, then steroids are given. So while the patients are using steroids, the allergy sort of subsides, the symptoms go away. But again, it comes. So if the patient is allergic to brimonidine, you have to stop it. Now, Dr. Siddharth, if a patient comes saying, I have redness because of, say, travoprost, how do you convince them? Do you try to convince them, or you straight away change the molecule?
No, I ask the patient, is that a redness that you can live with? Or is that a redness that you can't live with? Now, with prostaglandin analogs, especially when you start them for the first 2, 3, 4 weeks, I always tell the patients that, look, you are going to get redness and it is going to get better over the next 2 to 4 weeks. Now, beyond that, I know that it is harmless. The next question that comes is, can you live with it or you want to change it? Then I go from the best to the worst. It has been proven in studies nicely, and we don't have to be coy about that, that bimatoprost is the worst, travoprost is the second, and latanoprost is the best. The tafluprost molecule, which was available to us till very recently, is no longer available, was wonderful. And I cannot say how many patients benefited from it, but sadly it's not available. So that's the order that I go with, and I go stepwise manner. So if I think the patient needs a prostaglandin analog, I'll go in that manner, and I usually start with the best. I don't start with the drug that's the worst with redness. All said, I will also remind everyone that sometimes these companies come with a plan where they support the third bottle after the patient has purchased the second bottle. Now, for a patient who can't afford a lot, buying 3 bottles of prostaglandin for say $1,000, an original molecule which is really efficacious, means a lot to me. So I would try that out, and only then will I go to the next best option, financially speaking. Otherwise, for a patient who can afford, I would go with the best option that is available.
Thank you, Dr. Siddharth. It was very beautifully detailed. And Vardhaman, I think we can please go to the next session, please.
Yeah, thank you, Dr.
I'll interfere and say that my problem is in being extensively detailed. So please excuse me for that.
That's what we want. That's what we want. Thank you.
Yes, thank you, Dr. Siddharth. So thank you, Dr. Preeti ma'am, and all the experts for their pearls of wisdom. And I think, of course, after your medical therapy, and even in spite of using combination drug therapies, if the patient is still progressing, we have to look at the option of the surgical treatment in glaucoma patients. And we are going to now discuss about what are the common mistakes we have actually performed while performing the surgeries. And the first and a very important topic is going to be about the mistakes during trabeculectomy. And for that, we have Dr. Preeti ma'am again, Dr. Preeti ma'am is a prolific glaucoma specialist. She is the glaucoma surgeon practicing at the Kamdar's Eye Clinic, which has over 100 years of legacy. And she is a very prolific national and international speaker, has been always active in postgraduate teachings and all our Maharashtra Ophthalmological Society activities as well. Over to you, Dr. Preeti ma'am.
Thank you so much, Vardhaman and Team MOS for the opportunity. Mistakes in trabeculectomy. I'm going to tell you about, I don't know what mistakes others make, but I feel the most common mistake made by a comprehensive ophthalmologist is not operating when a person really requires trabeculectomy. But in the subsequent, in the form of videos, I've tried to bring up few mistakes which I have made in my practice and the changes I have made by which I'm able to sleep better after a trab, and this helps the patient also. So this is my mistakes in trabeculectomy. Most of the times I have had no problems while before this step. All my problems used to start after I did a flap surgery. I mean, after I made a flap. And what I used to do is I did not I would directly proceed to sclerotomy after a flap, and that led to a sudden decompression. So now I have incorporated this in my practice, where with a 26 number needle, I cause a very, no matter what the IOP, a very slow, gradual decompression. And that prevents so many complications of a sudden decompression. So after I wait for some time, about 5 minutes, then I go in with a side port. Now this side port, it's a little longer. It could have been better done, but no issues. After doing this, again, we know that the AC should be maintained during all steps of surgery. I was not doing that. Now what I've done is I inject air bubble, then I inject viscoelastic, and I create this cocktail. And this cocktail has helped me tremendously. Now this is the time when I have made this cocktail. I have put air and viscoelastic, and now I am proceeding with the sclerotomy. And here it's not full thickness, but now I go in and yes, I have penetrated, the air bubble has come out, and now I try to go full thickness. And this is the only problem with the air bubble, that it sometimes you have to clear it off. And now having done the sclerotomy first opening, I don't use a punch. Many people use a punch. I have tried punches of all kinds and I'm really not happy with it. So now I'm trying to make a sclerotomy. Even with this little bit of handling, you see that the anterior chamber is not collapsing. But see what has happened. I have got a shelved opening. So I have penetrated, but I have not made this sclerotomy is not going to work. And this is the mistake what I made was the blade was not perpendicular. When you try to make a sclerotomy, the blade should be perpendicular and it should be very sharp. So in a slightly hypotenuse eye, the regular side port knives don't work. Now, but one thing I wanted to highlight, now you're going to watch me suffer. But even with this suffering, you will realize that the anterior chamber does not collapse. So this is what I wanted to highlight, that after making a flap, put air bubble, put viscoelastic, sort of create a buffer and hold the blade perpendicular and use super sharp blade. And if you use the correct instruments, and then it is as simple as this, that the blade is perpendicular. Now I'm not going to make the same mistake. I have ensured that it is actually in the entire length of the sclerotomy. It has penetrated. And the vanas, with this vanas, I can make a very beautiful sclerotomy, even sclerotomy. The tip of the vanas has to be very sharp. And if you see, the anterior chamber does not collapse, because here also there's an air bubble and there's viscoelastic. The biggest realization is releasable sutures have been described since many years. But in the initial days of my practice, I was not using it. They are so easy to use. Now, this is just the basic releasable suture. You take a bite through the clear cornea. After that, you take this is the 10-0 suture. You take a bite through the sclera on either side of the scleral flap, how you would suture it with any other way, and then you pull it, leave the end a little longer, pull, 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 pull. Yes, and now you take 3 throws and pull out the loop. Yeah, this is the loop you have created. Pull out the loop, take 3 throws, and then you suture it really tight. The beauty is there is no hypotony. Earlier we were taught that, and now you cut this end very short. And obviously you will be cutting the corneal end also a little shorter, but enough so you can pull it on the slit lamp. So this is one thing which I was not doing, and I have incorporated that into my practice, and that has made all the difference. So what the mistakes to summarize I was making is I did not gradually decompress, which I have changed. I did not make a side port. I had difficulty in sclerotomy, and I thought I was using sharp blades, but I was not. And I did not use releasable sutures. So my messages: use 26-27 gauge needle to decompress. Use an air plus viscoelastic buffer. Now all blades are not the same. Use super sharp blades for a sclerotomy, and use tight and releasable sutures. We have become much better at doing manipulations to the bleb on the slit lamp. So tight sutures, in fact, are acceptable. And thank you all for a very patient listening.
Thank you so much, ma'am. I think there were great pearls of great surgical pearls that you have shared with everybody. And I'm sure that especially comprehensive ophthalmologists, they do traps on their own also many times, as you know. And I think by incorporating these pearls in their surgical practice, I'm sure that they are going to make this surgery more reproducible. And the success of trap is really important. So thank you again for your wonderful presentation. So the next, what we have is on the common mistakes in the MIGS. And for that, we have a very promising young ophthalmologist, Dr. Sahiban. She is from the Dasarath Eye Institute. She is a glaucoma consultant, and she has been trained at Shankar Nethralaya for in the form of glaucoma fellowship. And she is one of the pioneers of MIGS, and she is the first and the only one to perform live surgery of MIGS at a national conference. So over to you, Simon.
Thank you, Dr. Vardhaman, and thank you, MOS, for having me here. I'm extremely grateful and honored to be presenting. So my topic for today is top mistakes in MIGS. And as we all know, MIGS is still a very new niche in India, and we're all making our mistakes. So I'm going to be sticking with the crunch of time just to the broader mistakes that one can expect with MIGS, and not going into the nuances of each and every technique. So starting with, according to me, I think the biggest mistake that we make is in choosing the right patient for MIGS. And very often that is the reason what is quoted for the ineffectiveness of MIGS is because the right patient was not chosen for the procedure. So now we know that the best patients for the MIGS procedures are the ones who are suffering from mild to moderate open angle glaucomas. They can be pseudo-exfoliative or pigmentary glaucomas as well. And since over here, we're only expecting about, say, 20 to 30% drop in intraocular pressure, you don't want the patient's medicated intraocular pressure to be larger than 30 millimeters of mercury. And when you're targeting an intraocular pressure of, let's say, about mid to high teens, that is when mid to high teens, that's when the MIGS is applicable. I think the biggest indication for MIGS is when patients with mild to moderate glaucomas are unable to tolerate the medications, are suffering from side effects or compliance issues. So in this stage of glaucoma, it will be a little more aggressive to do trabeculectomy just for the sake of the fact that the patient is not able to tolerate the medicine. So this is probably the area where MIGS applies the most. Also, mistakes in choosing the wrong patients could include MIGS being done in juvenile open angle glaucomas, where we know over here the trabecular bypass procedures don't work because there is immaturity of the angle and the structures even beyond the trabecular meshwork. Then secondary glaucomas are something that MIGS is contraindicated in. Patients who have elevated the episcleral venous pressure. And also its role in primary angle closure glaucoma is still not very well understood. Also, another mistake which is likely to happen is inadequate preoperative assessment. When I say that, I mean choosing mild to moderate open angle glaucomas is the area where MIGS applies. And why I'm putting this slide on in a forum full of glaucoma specialists is because I do get these queries. So there was just the other day, I was having a discussion wherein a surgeon asked me that this patient, particular patient that he was looking at doing MIGS for, had an IOP of 30 and was uncontrolled on 4 AGMs. So was MIGS a good option? So when I asked him what was the visual fields, he wasn't really sure because the visual fields was never done. And according to him, he assumed that this was a severe glaucoma because the IOP was so high and the patient was uncontrolled on so many medications. So my message over here is that severity of glaucoma is not judged upon the basis of how high the IOP is or how many anti-glaucoma medications the patient is. It can only be judged on the basis of visual fields. Also, cases wherein you're targeting very low intraocular pressures, let's say in single digits or early teens, MIGS is not a good option. And by that, I mean particularly the implants and the trabecular meshwork excision procedures. So advanced glaucomas or normal tension glaucomas are not suitable candidates for MIGS. Also, a good preoperative assessment on your adequate visualization during the surgery is very important. Avoid patients who have peripheral anterior synechiae or corneal edemas or any sort of corneal haze which makes your visualization of the angle faulty. Also, strategizing when you're combining MIGS with cataract surgery. When you want to do your MIGS, is it before your cataract surgery or is the cataract surgery before MIGS is also something very important. So this is a video from a mistake that I myself made. This was a bang procedure that I was planning post cataract surgery, and I did not foresee that the cataract surgery will leave the cornea edematous, and this was the view that I got, and I had to abandon the procedure because with the first nick there was bleeding, and even after washing that off, the corneal edema added up to the faulty view of the angle, the hazy view of the angle, and I had to abandon the surgery. So strategizing when you, and especially when there is an incurring cost. Suppose the patient, signed up for a device or using Kahoot dual blade light. So all of this that the patient is paying for, you don't really want to take a chance. So you might as well, I recommend, do these procedures first and then embark on your cataract surgery. Also, ask your patients of any history of being on anticoagulants and stop it before doing any MIGS procedures, lest the risk of bleeding intraoperatively and you may have to abandon or your procedure goes ineffective. Interestingly, the only indication for a MIGS procedure in patients wherein you cannot stop anticoagulant is iStent implant. It is proven to be safe, and this is just on the basis of one report that we have, has been proven to be safe. The only trabecular bypass procedure which is safe while the patient is still on anticoagulants is iStent implants. Also very important is when we're beginning with a new procedure is the correct positioning of the patient. The rightful correct positioning of a patient in MIGS is supposed to be turning the head away from the surgeon. It's to be done 35 to 45 degrees away from the surgeon. So you're sitting on the temporal side and the head of the patient is turned away from you. And the microscope is tilted 35 to 45 degrees towards you. The mistakes that we make, yes, ma'am?
6 minutes are over. So,
right. So I'm almost done, ma'am. So the mistakes that we make over here is that if the patient is not rightly positioned, the view is going to be something like this. So all the structures are not distinct and they tend to merge towards each other. So this is the kind of view that you get when the positioning is not correct. On the other hand, when you turn the face further away from you, you get a good view of the angle. So this is a beautiful view with all the three distinct structures. So I think I will end my talk over here. These were enough number of pearls. I had many more, but there is time crunch, so I will stop here. Thank you so much for the opportunity. I hope I was able to get across some points. Yes.
Yes, thanks.
Thank you. Very nice.
Thank you so much. Simon. I think this is, as you were saying, it is a evolving, I think, phase in India, especially for MIGS. And I think mainly the last couple of talks are mainly for the practicing glaucoma specialist, I believe, more than the comprehensive ophthalmologist. But it's nice for the comprehensive ophthalmologist to have a bit of bird eye view about what is the newer advances and what are the, let's say, nuances of mistakes and how to overcome them, at least for their own knowledge. But thank you again for putting this together, and thank you for joining us. Thank you. So I think the last talk of today's webinar is a very relevant talk, because I think when we have failures of trabeculectomies, I think we have to, of course, rely on our glaucoma walls. And I think that is, again, a phase which is only touched by expert glaucoma surgeons. And to cover about the surgical mistakes that a glaucoma surgeon can make while learning as well as while doing the glaucoma valve surgery, we have Dr. Shikha Gupta. Dr. Shikha is associate professor at the prestigious RPC since 2016. She has authored more than 150 peer-reviewed research papers, and she had a long list of very prestigious awards that she has received, including the Arvo Roche Collaborative Fellowship Award, the AIMS International Award, Arvo Developing Country Research Fellowship Award, the Best Poster Award at the American Academy, the Young Investigators Award at the Asia Arvo, the Best Paper Award also for glaucoma at AIOS, and so on and so forth. She is spearheading the glaucoma research by guiding more than 10 thesis and PhD students under her at present at RPC. So thank you, Dr. Shikha, for joining us, and over to you for your presentation.
Thank you, Dr. Vardhaman, for the kind introduction, and I thank Maharashtra Ophthalmic Society at the outset for inviting me here. I'm showing a bouquet of complications with AGV and how to manage them. So
Sorting the valve right.
Video.
In many situations, we feel that we have entered our safe waters, but then something happens which takes away all the pleasure from both the patients and the glaucoma surgeon. These certain circumstances, they arrive uncalled for and leaves the surgeon unprepared. But once we know what all things can happen, we can be better prepared and deal with these situations to help our patients immensely. So this is the first case which had high IOPs post AGV surgery. He was a one-night patient, operated VR surgery, and we had implanted a AGV tube some time back. Despite multiple needling attempts, the IOP continued to rise after each episode of needling, and therefore it was decided that because of a thick Tenon's capsule around the plate, a capsulectomy should be performed. So we went ahead and debulked the Tenon's capsule and excised the capsule, followed by primary repair of the overlying conjunctiva and the Tenon's capsule to bring down the pressure. On table, it was found that the IOP had lowered and the conjunctiva was secured. This is the second case. This is a child who had undergone an AGV tube in the intracameral space. The patient is phakic, but it was found to touch the cornea in the post-operative period, and therefore it was decided that we will put in polypropylene anchor suture in front of the tube so that it could pull the tube back along the plane of the iris. This was the desired outcome. So 2 sterile flaps, partial thickness, they were fashioned in 10 o'clock and 2 o'clock position, and a 9-0 double-armed polypropylene suture was used to anchor the tube. So a 26 gauge needle was used to dock the polypropylene needle. For both the needles, it was repeated, and in the end, the sutures were fixed and the tube anchored behind. This was the third case. This was another lady who had undergone an AGV tube. She had operated VR surgery, silicone oil globules were present, and the AGV tube was placed in the sulcus. However, post-operatively, the pressures continued to remain high, and we could not visualize the tube within the sulcus, and it was seen on UBM that it was sequestered between the capsulo-iridic adhesions, and therefore a basal iridectomy was created and the tube from the sulcus was taken out in the intracameral space, and also intraocular trimming of the tube was done and it was little longer in size. So a basal iridectomy helped us to change the position of the tube from the sulcus, which was capsulated because of the iridocapsular adhesions, and bring it out in the intracameral space. This was another case which was operated via surgery and had oil blockade post-operatively. The oil meniscus globules can be seen around the tube. This is the meniscus sign which was seen, and therefore we decided to go ahead with the venting incision within the tube. So these vents have been described, which take away the oil globules and prevent the occlusion of the tube by the oil globules. However, intraoperatively, we could see that despite multiple venting incisions, the oil globule in the form of meniscus still persisted. And we thought that these venting incisions may not be enough for the IOP to get lowered. To deal with such a situation in a non-invasive manner without opening the conjunctiva, we first tried to aspirate the oil from around the tube, but that oil, because it was a silicone tube, it continued to adhere to the tube, and we could see that the oil meniscus was now in the tube and was not going to the plate. And we envisaged that this will take a long time in the post-operative period for reducing the IOP. As a result of which, we went ahead with the intracameral flushing of the tube. We took BSS, and by bending the tube a little bit within the intracameral space, we flushed around 20 ml of BSS inside the tube, and we could see that the oil meniscus was no longer seen. This was a case of AGV which had developed a tenon cyst around the tube, around the tube and the plate, leading to high IOP. So we routinely are doing needling of the AGV plate on the slit lamp, because these patients in the hypertensive phase require multiple needlings before they could settle down and IOP remains stable. So by anesthetizing the conjunctiva initially and in the swinging motion of the needle, the IOP can be brought down on the slit lamp only, without taking the patient to the OR. This is the case in which we had planned to put this tube in the sulcus, and we had made an entry with the needle, 23 gauge needle, behind the partial thickness scleral flap at around 2.5 millimeter from the limbus. But as we directed the tube through this opening, it went on to settle in the pars plana space. So this was a vitrectomized eye, and this could have been the case, but however, still due to the risk of vitreous, remaining vitreous, including the tube, we wanted it to settle in the sulcus. So we took the tube out again, and through the same incision, we directed it more horizontally along the plane of the iris rather than directing it in a posterior fashion. And through the same incision, it now came to be placed within the sulcus. So sometimes, because of the tube being directed posteriorly, the same incision can actually cause misplacement of the tube, which can be easily redirected on table, and these small things should be taken care of immediately at the table. So this was a case where hardly a stump of the tube is visible. This is an operated VR surgery again, and pseudophakic eye. He had multiple episodes of high pressure post-operatively. So, but it was not, resolving with needling. So we saw that there was tube retraction due to fibrosis around the plate, leading to high pressure. So we decided to extend the tube. So this was an indigenous method. We took a cannula of the venflon, cut it from the plate, and used it as a perfect extender to the tube. We pulled the tube out intracamerally rather than that is described by opening the conjunctiva and taking out the tube and then extending the tube and repositioning it back in the intracameral space. We just pulled out the tube in the intracameral space through the limbus, put the tube extender, beveled it, cut it short, and then reposited it in the intracameral or the sulcus space, and this patient continues to have stable IOP post-operatively. The length of the tube can be titrated according to one's need, and since this was a case of tube retraction, we wanted the tube to be a little longer in length in case of future retraction, which actually is now much shorter than as depicted in the final postoperative photograph in this case. So to conclude, we can have various situations, and these can be dealt in a more non-invasive manner, in a better way, if we know that these options are available to us. And implanting glaucoma drainage devices can be actually a life changer for the patients, and we should always give an attempt to salvage the vision of our patients. Thank you so much.
It was a wonderful presentation.
Stop
and
it. Stop share.
yeah, thank you, Dr. Shikha. It
Stop the
was,
video. Yeah, the voice is still on. Just stop it. Yeah.
yeah. No, we can't hear it because I think you have stopped sharing.
Okay, that's great. Yeah, great.
So thank you again, Dr. Shikha. I think it was great. Many surgical pearls in your very best fashion. I'm sure that our glaucoma colleagues must have definitely learned a lot of pearls from you. And over to you, Dr. Preeti ma'am, for the final panel discussion.
It's already 10:30, so I'll ask one question to each of the panelists. Rita, you train a lot of postgraduates, right, for glaucoma. So what are the most common mistakes they make during a trabeculectomy? Unmute yourself, please.
The first thing that I tell them is they have to make sure on history that they have to stop all anticoagulants, because that is, they forget to ask that. So you have to ensure that they doing the right pre-op assessment. On the table, I know there are a few things that, they invariably do. I mean, you've already shown some things that you do, but because they have watched us operate before, I think, they know that they can't go in and open the globe directly. They have to reduce the pressure gradually, come what may. I don't use the 26 gauge blade as you said, but I use an MVR blade, and I go in 3-planar. So once I go in 3-planar, I know that I've got a lot of time to get my pressure down. And only once the pressure is down, I always reform it with Visilon with some visco agent. So I know that I have a nice and deep anterior chamber, and there will be no chamber fluctuation whatsoever when you finally go in. Then what my students actually do is they can't use the punch very easily. So that is what I teach them. Therefore, on practice size, we do it on wet lab first, and then I get them to use the punch actually. Though I think it's a very simple thing to use the punch, and once you use the punch, you get such nice such a clear cut ostium that you don't have to really worry, and there's no fear of the iris edging out of that thing before. So you actually have to go in to pull up the iris. So that is another thing that they do, because they don't use the punch, they use sharp blades, of course, but even though they're using sharp blades, they do have a lot of iris coming out. That is something that, we have to work on them. Another thing that I have to work on them is they're doing SICS surgery, so dissecting the scleral plane is no big deal, but they forget that they are supposed to do very little cautery. Because if you do a lot of cautery, then your scleral flap shrinks so much that it's very difficult to get a suture. And since they have seen us do routinely, I'm nowadays doing before surgery, I start injecting MMC 0.01 cc's of 0.005 concentration of MMC. So no sponges are left. That is one thing. Otherwise, sponges are left. Before, I used to see that my students used to leave sponges. So that is one thing that we have overcome. And we have taught them the right way to do a releasable suture. That is all that we need to do. And good conjunctival suturing and no conjunctival buttonholing.
Rita, thank you. So the next question is to Dr. Siddharth, that LVP is doing a lot of MIGS. So what is your message to the comprehensive ophthalmologists, yes, and even to glaucoma surgeons who want to start doing MIGS?
Okay. I've been called upon after a long time, so I'll take my time, and excuse me for that. I'll start with what Dr. Rita said, Madam, I'm absolutely sure that you have trained multiple postgraduates. And I would like to share my short experience with you. The best trabeculectomy that I've seen as a surgeon who is doing their first trabeculectomy has come from a postgraduate student. And that has happened because they had practiced 300 sutures before they stepped on to do a trabeculectomy onto a patient. So I think the biggest hurdle that a person who is doing a trabeculectomy is the speed of suturing. And I faced that. By the time I entered entered the fellowship after doing residency at LVP, I was believed falsely slow, as I would state, to be a competent surgeon. And the first combined surgery that I did, can you believe me that I did the cataract surgery in less than 10 minutes? And then the ostium flap, everything within the next 10 minutes. And then it took an hour for that suturing. So I think in addition to whatever Madam said, is the crux of finesse, whatever Madam said, but the speed of suturing is another thing that the postgraduate students need to learn. And if they do 300 nylon sutures and 100 Viking sutures in wet lab, believe me that they will be the best trabeculectomy surgeons that you assist in your patient if you make them to do that. Coming on to the next, coming on to the next thing, how slow have we been? Can you imagine that eye stent was a rage in the Americas 5 years back? GAT was proposed as a surgical technique more than 4 years back in the Americas. Now, I am Dr. GC's student. I'm also Dr. Ravi Thomas' student, Dr. Rajul, for you. I don't take anything on its face value. I want to look at evidence. But at the same time, am I letting the entire world to bring that evidence to me? Or I take that onus upon myself to generate that evidence myself while being safe to my patient. In this brief last 18, 20, 24 months, many of which was forced by the pandemic, when I knew that I cannot depend on releasing that releasable for the trabeculectomy for the patient who I am doing the trabeculectomy for, who cannot come back to me. I need to do something that I know was probably less efficient, but required less post-operative care. So that forced me into mix. And I'm absolutely sure that every surgeon in our conservative institute will be a supportive member of this society, that MIGS are the way forward. Look, there is no doubt that there is a section of patients for whom MIGS is not an option. But there is a larger section for whom MIGS is an option. Now, when we say MIGS, we tend to generalize. And if you look at the American Academy of Ophthalmology position paper, we look at all the evidence, we look at the eminent speakers, and I don't know, right from the beginning of my fellowship, I have been a big fan of this Canadian Pakistani glaucoma surgeon, Ike Ahmed. Yeah. And I have been looking at his videos. Every video, the moment he posts, I'm probably one of the first viewers. So he experiments a lot, but he also gives a lot of what you can say, verified knowledge to you. Now, we are at a stage when we know that mix can be classified into 3 categories. The Schlem's canal implants, which are of a lower efficacy. Then you go to a stage of surgery when you do a Schlem's canal excision with trabeculotomy in the way of GAD, KDB, or GAT in many ways. Some of these are economical, some of these are dependent on very expensive devices. And then you have a class called the MIBS, the minimally invasive bleb surgeries. I really want to believe that the MIBS, the pressure flow, something else to start with, and Zen implant can actually, across races, across populations, be a challenger to trabeculectomy. They have shown absolutely amazing efficacy in terms of safety compared to the trabeculectomies. Now, whether they are as efficacious in terms of IP control, the number of repeated interventions that they require is a matter of whether they want to come to us and try it out. I'm scared by the fact that they have not provided us access to those devices. They are absolutely not available to us to try. The pressure for the Zen implant. But I'm absolutely sure that if I ever, God forbid, I'm a glaucoma person, I don't want to become a glaucoma patient. But if I become a glaucoma patient, instead of using a combination of prostaglandin analog, a beta blocker, and an alpha agonist, that is the first choice of 3 drugs that I prefer, I would probably prefer to undergo a mix and get rid of those 3 medications.
So those
I'm not saying at all that that is what my present stance is, but I'm looking at even say 10:46, which is very late in night for me, for someone who has to report at work at 7 o'clock in the morning, to look at with really bright open eyes. If you look at those patients who have allergy with brimonidine, patients who awake in the morning and come to you with the red eyes with the prostaglandin analog drops, can you do a surgery which has very, very few risks and provide a control of intraocular pressure that, if not perfectly, but very closely provide an alternative to trabeculectomy? And can I share a fact?
Can we
at LV Prasad Eye Institute, we very rarely do trabs instead of a GAT, and we are very happy with the results of this mixed procedure. And I would be very happy to share the understanding that we have developed with GAT, and I'm very sure we will learn from more surgeons who have done other procedures and offer them more to all the patients that we have. I told you in advance that my problem is that I'm very extensive, and I'll stop here. I will not say any more.
Thank you so much. It is now 10:45. I wanted to ask Shefali one question on what how to do a better thing, but I think we end
But
it
I
now.
think, I think
We
everything
end
has
it
been
now.
covered
So,
very
Dr.
precisely.
I
Dr.
just want
In
Vardhaman,
fact, I wanted to ask you questions, but Dr. Rajul has to say something.
I want to add just one, because Siddharth talked lots about mix. It is very good to collect data ourselves rather than relying on the Western data. But at this point in time, we do not have long-term data from the India. Doing Prasad doing GAT as a primary procedure is no issue, but I don't think that we should recommend any mix as a primary procedure across glaucoma. Early glaucoma is different issue. We don't have time to debate, so some other time, but I think the message has to be very clear that mix is evolving. We need to look really which are the good patients, and I don't think across the state open angle glaucoma, mix is not the choice of surgery first. I would prefer TRAB in advanced glaucoma, in other glaucoma also. So I don't think we should pass on the message that mix is a primary surgery. If they get long-term data, 5 years data, I think that would be a different thing, but not now.
I think TRAB remains the gold standard for at least moderate to
Now
advanced
end.
cases wherever indicated.
I think we now end the session. So, Vardhaman, if you could do the honors, please.
Thank you so much, Dr. Preeti ma'am. Thank you to all the expert panelists and also to the speakers. And before we end, officially, I would like Dr. Bide sir and also Dr. Anaga to announce some of the important events that has happened in terms of the glaucoma awareness.
Actually, thank you, Vardhaman. Excellent webinar on common mistakes. Very useful to comprehensive ophthalmologists. A lot of take-home messages, a lot of pearls to learn, a lot of lessons, what we should not do in treating glaucoma patients. And definitely everybody will use his or her wisdom in treating glaucoma. Thanks to the panelists, esteemed world-renowned panelists, I would say. Thank you very much. And over to Anaga, I think she has some announcements.
Yeah. Thank you to all the esteemed speakers and panelists. It was a wonderful session. And I think this has opened our eyes to all the mistakes. And I think this is our greatest teacher. And a lot of effort has been taken by all of you to compile all this. Really hats off to Dr. Vardhaman, Dr. Preeti, each one of these speakers and panelists for that. With regard to glaucoma awareness, MOS also has been instrumental in promoting glaucoma awareness among the general public. And in fact, in the last 1 month, in the month of March, we also had a painting competition where we had judges from Maharashtra, 3 judges, where we had a lot of entries from all over Maharashtra. And that helped to create a lot of awareness also. So thank you to all the judges and all the participants. We also had a photography competition for landscape, and in the next month we will be having one on wildlife, on animals. So looking forward to more and more participation for all our MOS activities, and this keeps us going. Thank you so much, everyone. Thank you.
Thank you again.
Thank you very much. Good night, everyone.
Thank you.
We have awareness program on SAM TV in Marathi. Dr. Preeti is going to be there, and Dr. Vinay Nangia is also going to be there.
Thank you, and special
Thank
thanks
you.
to Preeti ma'am to be the co-moderator, and over to Aditi to sum up the conclusion. Thank you.
And Vardhaman, I think Sunil is going to share some videos before Thanksgiving. Sunil, are you there? Hello friends, as you are aware that glaucoma is one of the leading causes
I'm resharing, sir.
This was a video that was dedicated to the painting competition.
Hello friends, as you are aware that glaucoma is one of the leading cause of blindness after cataract, and it is the cause of blindness which leads to permanent blindness. So detection of glaucoma at early stage is of utmost importance. For this reason, to create awareness amongst population, we at Maharashtra Ophthalmological Society decided to have a painting competition for all the population. And I am happy with the excellent response from all over Maharashtra.
I would like to really appreciate and thank Maharashtra Ophthalmic Society for coming up with this initiative of creating awareness about glaucoma, which is a silently blinding disease through the media of art. As a judge, I got to see a variety of artwork from children as young as 6 years old, which is amazing. So I think this is a really great idea, and congratulations to the entire Maharashtra Ophthalmic Society team on this wonderful initiative. Thank you.
Received a lot of applications here, and we were glad to judge, and I am thankful for them for giving me this opportunity to judge these posters. There were a lot of posters that we saw, very beautifully made, and the message spread across. So it was fun doing that, and thank you very much.
महाराष्ट्र ऑप्थॅल्मिक सोसायटीने यावर्षी ग्लॉकोमा अवेअरनेस या विषयावर पोस्टर स्पर्धा घेण्याचं ठरलं होतं. महाराष्ट्रातून सर्व वयोगटातून स्पर्धकांना एंट्री पाठवण्यासाठी आवाहन केलं होतं आणि सदर पोस्टरचं परीक्षण आम्ही केलं. मला सांगायचं की ती सर्व जे पोस्टर्स होते ते अतिशय नाविन्यपूर्ण आणि दर्जेदार होते.
A big thank you to all the participants and the judges for sparing your valuable time and for joining us in this awareness drive.
Thank you so much, everyone. Thank you.
Now the results of photography competition.
Good.
Thank you so much. Dr. Aditi, yeah, you can.
I would like to thank all the speakers and the faculty for wonderful session, very nice talks and great discussion. And I would also like to congratulate the winners of the photography and painting competition also. Thank you, Entor people, for supporting our program, and the technical team for a smooth glitchless program, and obviously our own MOS President, Secretary, Dynamic Scientific Committee Chairman, Dr. Vardhaman, and Preeti ma'am. So thanks a lot and good night all.
Good night, everyone, and thank you
Thank
all
you.
for
Good
a
night.
wonderful session. Thank you,
Wonderful
Vardhaman.
session.
Thank you, Dr. Preeti ma'am.
Bye.
Thank you, ma'am. Thank you. Thank you. Good night.